Şu an gözüküyor. Ben yavaş başlayayım. Abi şey anlarsın. Yani bu basit. Şey gözüküyor. Ya da şey yapabiliriz. Önce geçersen şeyde aktif fizyolojik yapıyoruz. Bizim için yeni zaman mı? Hayır, Almanya'da sizin aktif gösterdiğiniz babalar geçmesi gerekiyor. Ona bağlı. Ama başlık var. Başladın mı abi?
Başladım.
Yok gelmiyor.
Ha hiç gelmiyor. O zaman.
Şu an
Geldin mi? Geldiysen geç.
Hocam böyle geçiyor. Hocam biraz yardım.
Onu da işte öyle.
Beni yansımayın. Onu Sena'ya söyledim ben. Yok. Nerede harbi bir şey yapmışsın? Hayır zaten ikinci bilgisayar var ya. Hayır şey diyorum yani. Ben... Tamam çünkü şu an öncesini yok mu?
Morning, everyone. Sorry for the delay. I hope you all had a delightful evening and took the opportunity to relax and connect with your colleagues. It's wonderful to see everyone back here, rejuvenated and eager for the day ahead. Today promises to be full of stimulating discussions and groundbreaking insights. We are now ready to start our third session of this Congress. Let's carry forward the energy and enthusiasm from yesterday and make the most of our remaining time together. Thank you for joining us bright and early. Moderators of the third session are Dr. Kerim Sultan, psychiatry resident, and Selam Kara from the organization team. Let's get started.
Good morning. Can you hear me? Onu masaya. Good morning to all attendees. I'm very happy to welcome you all to the third session of our second International Neuroscience Days. One of your audiences, did you know that 1 in 4 people globally can be expected to have a stroke during their lifetime? Or do you know that 25% of people who recover from their first stroke will have another stroke within 5 years? All these findings make it today even more crucial to develop efficient and targeted treatments against strokes. During the past decade, the treatment paradigm for neurological disorders has shifted towards targeted therapies. As such, stroke therapies benefit from an individualized approach that considers differences in assigned treatment, especially for strokes. With this session, we are aiming to eliminate these targeted therapies and will dive into the pathophysiology of ischemic strokes. Professor Dr. Karl-Heinz from Goethe University and Professor Dr. Jean-Pierre from Cambridge University will enrich us with insights on neurovascular and degeneration. Let me conclude my sentences by thanking to Professor Claude and Professor Baron for their attendance and for sharing their expertise and insights with us today. I also want to thank to each of you for being here today and for taking part in this congress. I hope you are looking forward to the Congress and to the speech as much as I am doing right now. It is now my very great pleasure and honor to introduce our first speaker, Professor Karl-Heinz from University.
Yeah. Can you hear me? So, good morning, everybody. I want to start with thanking Beck and the other organizers, the entire team actually. I think you did a tremendous job. And I really admire the way you are organizing yourself, put your future education in your own hands and by organizing such an event. I think it's really admirable, and I hope you can continue like that. I'm a neuropathologist, and I realized by talking to several of you in the last 2 days that there is a great interest in clinical neuroscience over here, that many people are interested in becoming neurosurgeons. Some people ask me, what is a neuropathologist doing? And the answer is very simple. The neuropathologist is the servant of the neurosurgeon. So if you want to become a neurosurgeon, treat your neuropathologist well. That's the first message of today. The second message is that neuropathology is not a specialty of pathology. It's actually a neuroscience discipline. And this is something many people don't know. So neuropathology has evolved from either psychiatry, that's the German way. So the psychiatrists didn't understand what was going on in the many people's brain. So they thought we have to look at it closer. And the other way how neuropathology evolved was from neurosurgery, and that's the American way. So the great American neurosurgeons, they didn't understand why some people are doing well after surgery and others die, and they thought we have to look closer to that. And this actually then turned out in this great book, Tumors of the Glioma Group, by Harvey Cushing. I think the name is very familiar to you, and he joined forces with pathologists called Pascal Bailey, and they tried to understand the basis of outcome of glioma surgery. Some people did well, others didn't, and they didn't know why, because all of them were operated by the best neurosurgeon at that time, Harvey Cushing. And I just want to show you one simple example. So these are brain sections from patients with brain tumors on the left-hand side. What do I need to use the pointer? Okay. So you see the tumor here from this patient, and it's well circumscribed, right? And then there's another tumor which is bloody, which is not well circumscribed. And if you do histology on that, you see the border here. So this is a tumor, and if you do histology on the other one, you don't see a border. So this is a diffuse infiltrating tumor, this is a circumscribed tumor, and you know all from your studies that this one is a meningioma, and the other one is glioblastoma, and usually patients with a meningioma can be operated very well upon. There is this good prognosis, there is a chance of recurrence, but with the glioblastoma there is no chance at all. You can do whatever you want, you can send them to the best hospitals in the world, they will die with less than 2 years, despite huge efforts to treat it. And actually, one of the earliest experiments, so to say, was done in the 1920s by Walter Denby, an American neurosurgeon. And what he actually did was he tried to increase the area of resection because the tumor was always recurring. So he thought we must go into the normal brain to remove all infiltrating cells. And what he ended up is a hemispherectomy. So he removed the entire hemisphere just reading the basal ganglia inside. And he did that, if I remember correctly, on 12 patients, and in 9 of these the tumor recurred, which shows you that this is a systemic disease which cannot be cured by surgery alone. And what neuropathologists are doing nowadays is they're working on tumor classification. You know, there's a history of this guided by the WHO, and I was involved in all of them starting from 1993. There is actually, the latest one is from 2020. And what is particular about the latest one is that nowadays you can't do brain tumor classification without molecular analysis. And this is especially true for pediatric glioma. So there are subtypes which are indistinguishable by histology alone, and you need to do more. And I just want to give you one example how molecular pathology has affected diagnosis. So this is an example of stereotactic biopsy. So meaning that's a tiny biopsy taken out from a patient's brain, maybe just to have an idea what it is, or it was in a region where the neurosurgeon couldn't operate, so a vulnerable region of the brain where you do harm if you operate on it. So you need to have a diagnosis. So in the stereotactic biopsy, and what you can say, this is presumably a tumor, but there are no signs of malignancy, like necrosis, vascular proliferations. So how can you tell the neurosurgeon what it is? And what we do nowadays, we do genome-wide DNA methylation, which gives you nowadays roughly 1 million CPG sites, information on that, and you get a copy number profile, and this copy number profile is reminiscent for a glioblastoma. So although this tumor does not look like a glioblastoma, on molecular basis we can say this is a glioblastoma. So we call this molecular glioblastoma nowadays, and it's treated like a glioblastoma. And another example is this one, which actually looks like a malignant tumor because it has vascular proliferation shown here. This could be a necrosis, so these are the classical signs of glioblastoma. But if you do copy number profiling and DNA methylation, you don't see nothing. So it's actually a low-grade posterior fossa glioma it's so-called pilocytic astrocytoma, which has an excellent prognosis. But it could be misdiagnosed as a glioblastoma if you don't use modern technologies. Okay, so this was just actually an introduction for those of you who are interested in neurosurgery, neuropathology. If you are a neurosurgeon, then the neuropathologist will be your best friend. And if you are interested in talking to me about this, please see me in the coffee break or whenever. So what I'm going to present you is 2 short stories about 2 neurosciences which are forgotten. And then I will talk a little bit about the neurovascular development, and I will do that with 3 examples: tumor, stroke, and epilepsy. And in a way, I hope that I can provide the basis for what Jean-Claude is telling you afterward on stroke. So, anybody has heard of Ludwig Edinger? Hands up. Okay, very few. But all of you have learned neuroanatomy. You know there is a nucleus, there is the nucleus Edinger Westphal in the brainstem, which controls eye movement. So this is this guy. This is Ludwig Edinger, and he is actually the founder of neuroscience in Germany and in Europe. But most people have forgotten it. And you know, when neuroscience became organized as an institution which was at the beginning of the 20th century, there was the Brain Commission formed in London in 1903. And at that time, there were 3 existing brain research institutes in the world. The oldest one was the one headed by Ramon Cajal in Madrid, and then there were 2 more. One in Frankfurt, but headed by Ludwig Edinger, and the other one in Leipzig by Prof. So all other brain institutes came after that. So Edinger is actually the founder of the oldest brain research institute in Germany and the second oldest worldwide. So this is how he worked. It's a painting by Louis Corinth. And at that time, neuroscience was autopsy work. So we worked on brain sections and tried to understand what's going on. And this is how the people worked at that time. You see that there are already female scientists, but they were the minority. Now it's obviously just the other way around, which is great. At that time, smoking was still allowed. And this is the picture from 1905. So that's just when the institute was founded. And this is the Neuroscience Institute in Frankfurt. So it's a 5-story building. You can see it in the back. And on behalf of the 100th anniversary of Goethe University, we erected the stele to remember Ludwig. And then I want to talk about a second scientist, a forgotten scientist. His name is Philip Schwartz. May I ask anybody knows about Philip Schwartz? You're well educated, obviously. Okay, so Philip Schwartz may actually be of interest to you because he's very important for Istanbul. And what you can see here is the main entrance of Frankfurt University Hospital. So this is the main entrance, and in the back you see the building where all the patients are, right? And this stele remembers Philip Schwartz. Now, who was Philip Schwartz? So this is, I don't want to read you, I don't want you to read all of this. It's from an abstract from a Turkish pathologist. And the title of this abstract is German pathology professor Philip Schwartz's enduring life from Frankfurt to Istanbul during the Second World War area, the forgotten savior. And what the story tells is when Mustafa Kemal Atatürk actually reformed Turkey and also the Turkish universities, he invited scientists, he actively invited scientists from European countries to come to Turkey and to help him to modernize this. And one of those scientists was Philip Schwartz from Frankfurt. And Philip Schwartz, because he was Jewish, was also forced to leave Germany at that time. And what he did, he organized the so-called Emergency Society for German Scholars Abroad. So all scientists who were forced to leave Germany or wanted to leave Germany connected to him, and in fact he was able to bring 250 scientists, artists from Germany to Turkey and saved them from the Nazis. So that's the history of Philip Schwartz, who worked here for 19 years before he moved to the US, and he's considered as the founder of modern pathology in Istanbul. So this is a close-up of Philip Schwartz, and you see these figures actually make up the names of the scholars he served. And this is the book, this address book of the scientists who were threatened by the Nazis and were forced to leave Germany. So now I'm actually coming to a more scientific topic, and message number 3 would be that almost all neurological disorders are associated with a dysfunctional blood-brain barrier. And I just give you some examples here, like traumatic brain injury, retinopathy, infections, neurodegeneration, tumor, stroke, and epilepsy. And I basically will focus on the last 3 as an example of how this may have an impact. But before that, I will give you a very brief introduction on neurovascular development. So how does the vasculature actually comes into the brain? How does this work? And this is quite well understood. So the blood vessel forms early in development in the yolk sac. These are so-called progenitor cells, which still have the chance to either become endothelial cells or blood cells. So they are undifferentiated. But then they move out, to the brain region and form what we call a primary perivascular plexus. So these are primitive endothelial cells which are no longer able to become blood cells. Their fate is decided, and they come to the brain surface. And this is controlled by growth factors which are well understood. VEGF is the most important of them. And then when this primitive plexus is formed, there's endothelial sprouting, what we call angiogenesis. And then there is maturation, which requires other signaling pathways, other cell types, neural cells, pericytes, fibroblasts, and so on. And how this works in the brain, I will show you here. So this is the cortex, this is the perineurovascular plexus, so the brain surface, and this is the ventricle, okay? So in the beginning, the vessels are outside the brain, they are on the surface. And this is something we call extracerebral or leptomeningeal vascularization. And then the second step, the vessels invade the brain, but they do it in a specific manner, namely they go down, they go to the ventricle. And then there is a third phase for the white matter, and then the cortex is the final stage. So this is at the end of the development. Okay? And the question is, why does it happen in such a specific pattern? And the answer was shown in, by a group at the Max Planck Institute in Munich, where I was working at that time, by Werner and Saul. And the hypothesis is that the signaling must come from the periventricular area to guide the blood vessels deep into the brain surface. And the growth factor which was discovered at that time is VEGF. And this is a in situ hybridization, how it was done in those days, using radioactive sulfur. And you saw the expression of VEGF in the ventricular area. So this is the surface, this is the ventricle here. And then it was also shown that the receptors are coming from the surface and move into the brain region. And this also fits very well with the downregulation of VEGF receptors, which are shown here. So this is at birth, day 10, day 20, and at day 30, it's no longer visible, whereas PCAM1 or P31, which is an adhesion molecule, is constitutively expressed. So the expression of VEGF and its receptors fits quite well with brain angiogenesis because it's downregulated when the vessels don't grow anymore and mature. And then it was also shown by Peter Conrad, for example, also by Napoleon Ferrara, that VEGF is important for vascular development because a heterozygous knockout, so if you have only one allele of VEGF present, is not able to make a mouse survive. So a mouse needs a certain amount of protein at a certain kind of development in order to go further. And if this is not present, the mouse will die. So it's not a total knockout, it's only 50% knockout. And then also in the Resau lab at that time, we showed that if you have a brain-specific VEGF knockout afterwards, then the blood vessels stay. So this is again is the mouse. So this is the nose. These are the ventricles. Okay, and this is the control where you see the blood vessels are in the parenchyma, but in the knockout, the vessels remain in the extracerebral surface, so they can't invade the brain because the signal is missing. And the brain looks like this is like a total brain infarction. So there are several signaling pathways which regulate brain vascularization. This is a list which is not complete. There are even more in signaling, for example, is missing, which is crucial for blood-brain barrier development. But what is interesting is that some of these are trackable and others are not. And for our studies, we decided to work on those which are trackable because we wanted to work on questions where we would connect with pharma in order to do something which would be of potential help to future patients. So we decided to specifically work on VEGF signaling and on type 2 angiopoietin signaling. And I will explain you in a minute what this means. So this is basically the hypothesis we are working on for, I don't know, 20 years or so. And what we think we and many, many others have shown is that in the brain, in the adult healthy brain, you need a stable vasculature because the brain is so vulnerable, the neurons are vulnerable. So you need a stable system, and this is achieved by a very tight vascular system with an intact blood-brain barrier. And the signaling system which is required to achieve this is that the angiopoietin type 2 system must be switched on, because this type 2 is a receptor tyrosine kinase, and if it is on, it stabilizes the vasculature. If it is off, it destabilizes the vasculature. It's important for the connectivity between endothelial cells and pericytes. So VEGF I've been talking already about. So VEGF is important for vascular development, also for tumors, but in the normal brain it must be off. Okay, so this system must be on, this must be off, and with wind it's the other way around. It must be on, because wind is important for the stability of the blood-brain barrier. And what happens in pathology is actually that all of this is reversed. So type 2 is off, so it's destabilized, VEGF is on, the vessels sprout again, and wind is off. And in order to restore this, you have to work on at least 2 or 3 signaling systems. And I want to show you 3 examples, 3 clinical examples, how we address this. First is cancer, brain metastasis. So you see in the center of brain metastasis is the blood vessel. You see that this is must be a press-to-brain metastasis because the cells are HER2 positive, and you see the myeloid cells, the macrophages, the CD8 cells here in the stroma. But we also realized that the vessel is actually in the center of the entire program, because this is the way how the tumor cells enter the brain. So blood vessels are crucial. And the question we asked, can we tighten or can we normalize the blood vessels to prevent colonization of the brain by metastatic tumor cells which are circulating in the bloodstream. And the concept of this is based by findings from a scientist from Harvard Medical School, Aksel. And he opposed a previous hypothesis based on by a famous pediatric surgeon, Judah Folkman from Children's Hospital. So what Judah Folkman proposed, and what many people are, what we're working on, including myself for many, many years, is that, for example, if you got a tumor which needs support by nutrition, by oxygen, so it needs blood vessel, you can stop that by blocking the tumor angiogenesis factor, which was not identified at that time. So it was pure speculation, pure hypothesis. However, what has turned out, if you do that, if you prevent vascularization, you can actually make the tumor more aggressive because it becomes hypoxic and it switches on other signaling pathways which enable them to migrate far further than under non-hypoxic conditions. So Rakesh Chang, he actually turned this into a different hypothesis. He said we don't have to kill the vasculature, we just need to normalize it, so get it back to normal. And this is the term he coined as vascular normalization. And we did that in a study of brain metastasis. So this is a prevention study simply to test the hypothesis if we can delay, increase brain metastasis if we normalize the vasculature. So, and we did that by treating animals with inhibitors of VEGF and angiopoietin signaling. And then, as you can see here, the number of metastases is indeed much lower in the treated animals compared to the untreated animals. So indeed, there is a way to prevent metastasis. We also showed that this is due to blood-brain barrier properties. So this is a so-called TER, transendothelial resistance, where you culture endothelial cells and measure the resistance, which shows them whether they are tight or whether they are weak. And you see that these treatments make blood vessels weaken. And this is just an example of how this looks like in an animal. So this is the green is the tumor cell, and it's in the vessel, but it's on its way to come out. Okay, it's on its process to leaving the vasculature and go into the brain. And this is the same experiment in a mouse where angiopoietin 2 is overexpressed, so it's a leaky system, and you see that most of the cancer cells have already left the vasculature, okay? Suggesting that this signaling system is important for this process, and therefore is a valuable target. And we came up with a mechanism also how this works. So what we observed by 2-photon microscopy is that the tumor cells actually get stuck at bifurcations of the vessels. And then the blood flow ceases. And when the blood flow ceases, you get ischemia, and the consequence of ischemia is hypoxia. So this area will get hypoxic, and if it gets hypoxic, it upregulates hypoxic signaling for one if. And one of these is angiopoietin 2, and this leads to a leaky blood vessel. So this is the mechanism to explain how the cancer cells actually get into the brain parenchyma. Now I switch now to stroke. A couple of years we discovered that if we look at human brains, so this is a normal human brain, this is a stroke, what we call grade 1 pathology, so it's an early phase where you see edema lubrication, and then there is stroke grade 2, which is the later stage, and then there is also stage 3, which I didn't show here. What we observed is that one of these signaling molecules is specifically upregulated in the vasculature of the stroke patients, but not in the normal brain. So the question is it just a biomarker, or has it any functional consequences? And in order to study this, we use the transgenic mouse, which overexpresses the signaling pathway. And we applied a simple middle cerebral artery occlusion model. And what we can see is that the stroke size is much larger in these animals which overexpress it. And we can also observe that the permeability is much higher. So again, we tested that in an in vitro system, like the TER system, and you can see here that indeed there is increased permeability, so the vessels are leaky, and this is specifically true for low molecular weight traces, whereas the higher molecular weight traces can't pass. And there's also evidence from ultrastructural studies, so we can show, so this is a normal endothelial cells, but there are much more flaps in the endothelial cells, so there's many signs of increased vascular permeability. So the question is there a way to use this in a therapeutic manner? So if the signaling pathway increases stroke, it might be useful to prevent it, to decrease stroke. The question is it possible? And to do so, I have to increase another molecule, because you have to find, if you are interested in a certain signaling pathway, you have to find ways to target it, to address it. And one way is to block the receptor signaling. You can block away the signal, the ligand using antibodies. But there are also sometimes other ways. And here, what we here use is the finding that this receptor is under control of a phosphatase. So this receptor, so receptor tyrosine kinases, as you know, usually are need to be phosphorylated in order to work. This is also true for type 2. And the phosphorylation is reduced by this ligand and it's blocked by this ligand. However, there is another control system, which is a phosphatase, which dephosphorylates this receptor. So if you block this phosphatase, then this receptor will get phosphorylated and activated. So there is a way to target the system by blocking the ETPT, and this is what we actually did using these molecules, and this is shown here that we indeed are able to do that. So if you look here, for example, so this is phosphotype 2, and you see phosphotype 2 is present when we add ETPT. And we applied this in our stroke models, and what is shown here that the stroke size indeed is decreased by blocking this pathway, and this is also true for vascular permeability. So there are ways to target the vasculature to prevent or treat stroke. And then finally, just a few words about another project, epilepsy. In a way, we applied the same program to epilepsy. And the reason for that is that there is evidence that the leaky blood-brain barrier can induce epilepsy. Okay, I think everybody would agree that the other way is the normal way. So that blood-brain barrier dysfunction, edema is a consequence. And this is also what I believe. But then our neurologist, epilepsy neurologist, told me, oh, I learned that there's also an option that is the other way around. And I thought, well, never heard of this. And we looked at the literature, and actually there's quite a huge amount of literature around from people suggesting that small events like small infarction, a very localized infection can lead to opening of the blood-brain barrier, and if it's in the specific region, as the local hippocampus, it can induce epilepsy. So there is evidence for that. So we tried to do that, and we sent one of our residents to David Henshaw in Dublin to learn the technologies how to induce stroke in models, and the outcome was that it worked. So when we target the blood-brain barrier and tighten it, we can increase seizure frequency and seizure duration in mice. And this is one of the projects we are currently still working on. So to sum this up, what I was planning to show you that in the normal healthy brain, there are signaling pathways which maintain blood-brain barrier integrity, and this is of crucial importance for brain function. If this is not working, the brain will be diseased. It is independent, this blood-brain barrier breakdown is actually independent of the disorder. The pathways are quite similar, so it doesn't really matter whether it's stroke, brain metastasis, meningitis, glioblastoma, or whatever. The signaling pathways altered are the same, and what happens is that type 2 is turned off, VEGF is turned on, and WNT is turned off, and then you get the situation that the neurovascular unit is no longer functional, there are leaks, there's edema, which leads to increased intracranial pressure, immune cells come out, and you get the circulus. But you can treat that by returning the pathways by inhibiting VEGF and by turning on type 2 signaling. And what the last thing I showed you was that we think that the same thing could actually be true for epilepsy as well. So to sum up, what I wanted to show you is that neuropathology is a neuroscience discipline. it's not part of pathology. Brain vascularization occurs early in development. Hypoxia is a major regulator of blood vessel growth, permeability, and vascular function. And both these pathways are hypoxia-inducible in a dependent manner. And these signaling pathways are critically involved in vascular disorders such as brain metastasis, stroke, epilepsy, and many others. But, and that's the good news, neurovascular disorders associated with increased permeability are tractable. And with that, I'd like to thank by showing you my hometown. These are the people in my group. We have a collaboration with the Epilepsy Center in Frankfurt, with the Neurology in Frankfurt, and with many others. Thank you for your attention.
Professor Heinz, thank you for sharing your insights in the class. If you have any questions, please feel free to raise your hand and we will let you know. Is there any questions or contributions?
Can you hear me? Thank you also for your presentation. I want to ask, as we know previously, some tumors are more prone to metastase central nervous system and brain, such as lung and breast cancers. Does the difference of molecules and receptors that expressed from endothelial cells, capillaries in between central nervous system and other organ tissue system, lead some tumors to be more prone to metastase central nervous system instead of other organ tissue cells? What's the difference? The capillaries, the endothelial cells, express any other receptors than the other organ systems?
So the question is, if I understood you correctly, why some cancers metastasize to the brain, others don't, and why, for example, prostate is specifically going to the bone instead of the brain. Is that the question?
Yeah, like they're all in the capillaries, as we know.
Yes.
They're metastasizing through the hematological way.
Mm-hmm.
So why aren't they metastasize any other tissues?
Mm-hmm.
Why are they going to brain?
Yeah.
The capillaries, are they differ?
Mm-hmm. This is an excellent question, which is not fully understood. There is some specific signals for certain types of tumors to go into the brain, but this is not really clear. So this organ specificity is actually something that you could solve. You could tackle that. Yeah, it's you have the big three killers, which is lung, and which is breast, and which is melanoma. So these three make up 90% of our brain metastasis, whereas others are rare. And as a consequence of this, many people focus on the three, but are not working on kidney or others. So to fully understand that, I think it's something for the future. For the future generation, it's only very partly understood part.
Maybe there's a key log match between tumors of lung and melanoma between the capillaries of the brain.
Yeah, maybe.
Thank you.
Thank you for your presentation, Professor.
Yeah.
Sorry. Sorry. Thank you for the presentation. I was curious that you mentioned how stroke volume was reduced in rat models by restoring the signaling of TIE2 receptors. I was curious about how you induced those strokes in the rat models to assess the stroke volume.
So we used a mouse model here, not a rat model. And the reason we are currently we are switching from rat to mouse is that if you work with mice, you can use transgenic mice. And that's this huge advantage. So transgenic rats are rare. So it's a simple standard procedure, so-called middle cerebral artery occlusion, that you operate and you clip the middle cerebral artery, and then you reduce the stroke. So it's what medical students are doing for their health.
Thank you so much.
Thank you so much for your wonderful speech, Professor. You mentioned targeting blood-brain barrier for an anti-pathogenic effect. And we, in our society, we previously discussed blood-brain barrier opening rather than tightening for therapeutic effects in diseases such as Alzheimer's, like ultrasound-focused, ultrasound-guided blood-brain barrier opening. So I was curious about how it would affect the efficacy of anti-pathogenic drugs, for example. Would it be combined with anti-epileptics, or would it be in clinical settings a treatment just by itself?
Yeah, that's actually an excellent question. You are pointing into the right direction. So there is actually, you could argue that it is actually necessary to open the blood-brain barrier open in order to get the drugs in, right? And this is one of the major problems in neurology, that the brain is not well druggable because most drugs make it beyond the blood-brain barrier, so they circulate, but they don't work. And of course, it's valid to think in the exactly other direction. And just to show you this discrepancy, I once was a member of two consortia. One was the aim to shut down the blood-brain barrier, and the other one to open it. Yeah. So, however, there might be something in between, because what has been shown in this vascular normalization experiment for many people is that if you normalize the vasculature, you also can increase the chance to get drugs in, and also the chance to, for example, to get lymphocytes or so via a certain barrier. But I think this issue is critical for clinical applications, but it's not totally solved. And I think it might also be dependent on specific issue you're dealing with. So if you are dealing with a patient who has a lesion, let's say a tiny lesion, let's say a hippocampal lesion, which produces an epilepsy, it might be useful to just target this area, and whether then it's better to open or to close the blood-brain barriers, I think might be dependent on the condition, what's behind it. And therefore, I think there is no general answer to your question. But you're absolutely right.
Thank you. Are there any more questions?
Thank you for the speech. I was wondering if there is a way to detect those signal abnormalities in the brains of humans to maybe prevent strokes, epilepsy, and brain metastasis. If there is a way to detect those abnormalities.
So if you are talking about patients, or
I mean, I understand that we can maybe detect the signal abnormalities in mice, but is there a way to detect them in humans?
when they are there, we can detect this, for example, in the autopsies, but I think you are more, your question relates more whether there is a way to prevent it, and whether then you would identify patients at risk, for example, to stroke or for metastasis.
Yeah, I was wondering if it's possible to do it in a living human.
Well, if you take biopsy, then of course, yeah, and we can do that. And this has been shown. But I think the critical issue is if you want to treat, you have to find an indication to treat that it makes sense. And so if we would find, if we could identify patients at risk for a certain event, like a stroke, like a metastasis, this would be actually the right, that it's a real challenge to prevent the in the clinic. But it's absolutely important.
Yeah.
I have a small question. Thank you for your speech. Did I get it right? If we can, because the part with the epilepsy, if we can treat the blood flow, if we normalize that, we could prevent epileptic, the epileptic completely, or maybe partly, or can we reverse it?
Partly. So what we did is just is a proof of principle experiment. So to show whether this hypothesis that blood-brain barrier leakage is not only a consequence but can be a cause. This is what we tried to show, and I think we have evidence that this is true. So the number of seizures and the frequency of seizures and the duration of seizures is less if we tighten the blood-brain barrier and then induce the epilepsy. Okay?
Thank you so much. Any more questions?
Professor Aksel, really thank you for that outstanding presentation. Now, on behalf of the team, we would like to present with a little remarks. For that, I'm kindly inviting my colleague, John Chakmach and Rosalie Jeff to the stage.
Wow. I almost killed you know, myself. You're good.
Our next distinguished speaker is Professor Güher-Saruhan from Cambridge University, who has investigated more than 46 years in the study of stroke and neurological forms. Now we have us the presentation of pathophysiology, ischemic stroke, and subsequent
Oops.
I can.
Thank you. Can you hear me?
It's already.
Does it work? Yeah. Thank you. So thank you for the organizers for inviting me, and as Karl-Heinz said, I really congratulate you for this vibrant group of young people who are apparently very bright, and it's very stimulating So I will talk about pathophysiology of ischemic stroke and subsequent neuronal events. I'm based both in Paris and Cambridge. Actually, at the moment, more in Paris, but I'm still affiliated emeritus professor at Cambridge University. So just, I think it was mentioned how stroke is a serious problem worldwide, and the incidence is increasing actually. So you have, of course, two main stroke subtypes, ischemic and hemorrhagic. Ischemic is the more most frequent. And as part of ischemic stroke, you have three main types: embolic, artery to artery, for instance, from a carotid plaque, or cardioembolic from the heart, thrombotic, whereas the thrombus forms locally in the large arteries or small arteries, like in arterial sclerosis. And quite rarely, but it does exist, hemodynamic, low flow states, distal to chronic large arterial occlusion. But today I will focus on the embolic proximal MCA middle cerebral artery MCA occlusion type, because the most frequent type of ischemic stroke and the most studied both in animal models and humans. You have here an example of a clot blocking the middle cerebral artery at this spot. This is the internal carotid artery, and this is the anterior cerebral artery. Oops, the colors are a bit strange, I'm sorry. So, until about 50 years ago, 45, there was a dogma, when I went to medical school, I was told that after an ischemic stroke, like in cardiac arrest, the neurons die in a matter of minutes and there is no way they can be salvaged. But this was wrong, and one major finding was the description of the meningeal arterial anastomosis of the human brain by these two great people. And what are the leptomeningeal collaterals? Well, we can see an example with the case we started with occlusion of the MCA. And you see that on the angiogram, so this is the dye coming, and you see that the dye comes from the anterior cerebral artery into the middle cerebral artery, and even retrogradely back to the other end of the plot of the thrombus, which is here, and you have the dye that goes right to the other end of the plot. So it's not at all like cardiac arrest, because there is a degree of flow, of blood flow, cerebral blood flow, which is retrograde after a stroke. So it's not at all a zero flow condition. So, you know that we have at the base of the brain the circle of release, and we have these anastomosis, which are, end-to-end anastomosis. So when the pressure in the middle cerebral artery branches go down because of the occlusion, then just by the pressure gradient, so the blood flow will immediately flow retrogradely towards the clot. The situation is not the same in the deep territories. Here you have the perforators, the striatocapsular arteries from the middle cerebral artery. And you see that there is very, very little, although there are, but there are small, only small anastomosis with the rest of the brain, which means after an occlusion, the residual blood flow will be much lower in the deep territories, which are therefore more vulnerable. So, as I explained, when you have this occlusion, you have the pressure goes back, brings the blood flow back, and therefore, if you map the cerebral blood flow, which is called CBF, in mils of blood per 100 grams of brain tissue per minute, around 50 being the normal, you can imagine that because of this system, the worst blood flow would be close to the center of the middle cerebral territory, whereas blood flow will be preserved in the distal end because of the collateral. So it's like an onion ring of degrees of blood flow reductions. And this was a very important discovery from the 70s. And then Lindsay Simon, a neurosurgeon from Queen Square in London, discovered and described the ischemic penumbra, which was a major discovery in animals, in baboons, with proximal MCA occlusion. And what they found was that when they did electrocorticography, various parts of the cortex, they related this to the local blood flow, and they found that from 15, which is the normal, down to 20, which is quite reduced, 60% reduction, the electrocorticogram was normal. It's only after 20, so 60% reduction of blood flow, that the electrical activity of the neurons went down. Yet, when they studied the electrolytes, they found that as a function of blood flow, the sodium-potassium homeostasis was preserved below 20, despite a reduction in neuronal activity. And it's only, they found only around 10 mils per 100 grams per minute, which is an 80% reduction, that there was a leakage of potassium from the neurons. Therefore, they defined this area between 20 and 10 of perfusion, which had reduced neuronal activity, but the cells were not dead because their homeostasis was preserved. And therefore, they came up with this graph of a core, ischemic core, which would be below 10, and this is, neurons that are dying or already dead, and an area of penumbra where the blood flow is less reduced, above 10, but below 20, which is potentially viable. So at risk, but viable. And then in 1976, we published this major paper, sorry I had the problem, where they removed the clip after some time, I think it was 1 hour, 2 hours of occlusion, and they studied the evoked potential in the cortex. This is again open skull. They found that in the penumbra, the evoked potential went down almost to zero, but on reperfusion, you see the MC occlusion was this high. In the penumbra, the neurons recovered. So they demonstrated that reperfusion could salvage the penumbra. Of course, this was a major discovery, but this was done in animals. Then further studies showed the dynamics of that, and these studies also from Harvard showed that in fact the threshold that the lymphocyte found at 10 mils per 100 grams per minute was in fact dependent on time. So with very short occlusions, actually, if you reperfuse, you have no infarction. It's only with time that you will find an infarction. For instance, if you have a blood flow of 10 mils, it will be infarcted only after an hour and a half of occlusion. And if you have a blood flow of 20, then it will survive up to 3 hours. So this is like the therapeutic window is time dependent. Time is brain. So this you can, I'm sorry about the colors, but they're all mixed up. It's not at all what I prepared. But anyway, I hope you can still see. So this is the map, you know, the core, the penumbra, and around it, reduced blood flow, but not to the threshold of penumbra, which we call the epileukemia, which is asymptomatic, as compared to the penumbra and core, which are symptomatic cause symptoms. So this is a snapshot, but if you have the history, just after occlusion, there is no cause. All the tissues, penumbra can be restored. This is the equivalent of the transient ischemic attack, when people are paralyzed for 10 minutes or 20 minutes and they recover completely because of the natural spontaneous revitalization. But with time evolves, I hope you can see in 1 minute, 30 minutes, the penumbra dies, as I just showed on the graph, and the core grows at the expense of the penumbra until here shown at 6 hours, for instance, there is essentially no penumbra left. So if you reperfuse at this time point, you will save all this penumbra, but not the core, which is the final infarct. So as I said, time is prime. So the question was, then does this ischemic penumbra exist in man? There was no way to repeat these experiments, including the middle cerebral artery, open the skull, the electrodes, etc. So you had to have some non-invasive way, and the non-invasive way was the imaging techniques called positron emission tomography. I have no time to go into this. It's complicated studies and techniques using oxygen 15, which is a tracer that has 2 minutes half-life. And these studies from the early 80s, so it's a bit long ago, documented that you had this situation after like 3 hours after an occlusion of the middle cerebral artery. You have an area of very much reduced cerebral blood flow, below 20 mils per 100 per minute when we measure it. But the oxygen consumption is, as you can see, relatively preserved. So there's a kind of mismatch between blood flow and oxygen consumption, indicating that the neurons are still viable, still living, consuming oxygen that is coming from the trickle of blood flow, and this translates as a very much increased oxygen extraction fraction. The normal is around 40% of the oxygen that is extracted by the brain, but here it goes up to 100%. So this situation of critical ischemia, where the neurons are still alive, was thought to be the penumbra. This was proven by a number of experiments. You can see that in this particular patient, you have an area in the deep territories of the MCA where the oxygen consumption is close to zero as compared to the other side. And this is already the core of irreversible damage. And we did studies that established that this was indeed the penumbra, the volume of the core correlated with the admission neurological score, the volume of the penumbra as well. So they are both symptomatic, and the sum of the two had even a much higher correlation. So this was documentation that these two compartments explain the deficit, whereas the volume of polydemia, the mildly reduced blood flow, was not correlated with neurological score as expected. We also documented the variable fate of the penumbra. Here is the patient, it is the same pattern as we saw just saw of penumbra. This patient unfortunately did not recanalize and had this infarction. Whereas this patient, who has exactly the same pattern of penumbra, was lucky enough to recanalize after the PET study and had no infarction. We also documented that the volume of penumbra that survived, that escaped infarction, was linearly correlated with the neurological recovery. So salvaging, rescuing the penumbra is the main factor to improve the patient's outcome. So we also did studies in the baboon too, because in humans you can just do one study, it's too complicated. Whereas in the animal is anesthetized, you can do repeated event studies. So this is a baboon that you have the permanent MC occlusion, and you can see that this is before occlusion, and after the occlusion you have again the same pattern of low CVF, high OEF, and almost no CMR2, except in the deep territory. But as time evolves, you see the growth of the core into the penumbra, and this process lasts, even at one day, it's not finished. So it's not the minutes that my old professors was teaching me, it's a matter of hours and many hours. It's very important to understand this. Now, if you did the same experiment, but recanalized at 6 hours, you see that you stop this. I'm sorry. This is, no, this here it is, sorry. If you do the reperfusion at 6 hours, you stop this process of growth of the core, and you have saved an extensive bit of penumbra. And this is a study we did in these baboons, and measuring with post-mortem the volume of the infarction, and showing that during the recanalization at 6 hours, we had to considerably reduce volume of infarction and not even an overlap between the two groups of baboons. So the ischemic penumbra is the target of acute stroke therapy, and the core penumbra model is dynamic. So you can again illustrate this with this cartoon. So this is the situation of a patient you see at 3 hours, for instance, after the onset of MCA conclusion. So there is already a significant core, unfortunately, but there is a large penumbra. If you do nothing, this is what happens, the whole penumbra goes to the core and is irreversibly dead. But if you recanalize, you say the penumbra, so you have a much smaller impact of the brain and therefore a much better outcome. So I'm sorry again for the presentation because normally they all have a background dark to help read the captions. Anyway, so I told you that post-transition tomography, which is not clinically applicable for stroke because it's too urgent situation. But fortunately, there are surrogates in the magnetic resonance imaging, with that you can map the core, which is represented by the diffusion-weighted imaging lesion or restricted water diffusion, cytotoxic edema, and you can map blood flow. So here it's not blood flow, it's the transit time of the blood. So this is increased, not decreased in case of occlusion. And you have this area of very much increased transit, mean transit time, and the difference between the two is called the mismatch, and this represents the penumbra. Here we have the occlusion of the MCA on the MR angiography. And we validated in humans the threshold for the mean transit time, also called the Tmax, that represents the penumbra against PET. So this is quantitative and it's validated. You can use it in your patient tomorrow. And with this technique, you can, of course, show much more details than with PET because it's much easier. So here you have an example of a patient with the big mismatch. And who has the occlusion. This patient was given thrombolysis and recanalized. You can see the recanalization. And this is the final impact. So you say to all this bit of the number, whereas this patient has the same pattern, but unfortunately this patient recanalized but only partially. You see it's the clot just moved a few centimeters, and there was no salvage at all of the whole penumbra. So we also showed that, contrary to previous beliefs, in humans, you could see the penumbra here shown in yellow, projected on the final infarct. You see the penumbra, and here would be the core, was present in this patient 8 hours, and in this patient 16 hours of post-stroke onset, meaning that that there is in some patients a way to reperfuse these patients quite late, much later than was ever believed. So, and also documented in this Lancet paper that apart from the penumbra, the large penumbra pattern that we showed, some patients very early, even 2 hours after stroke onset, already had an extensive core. So these are patients with poor collaterals, it's genetic. So the penumbra has died very quickly. And other patients, so instead of having a hypoperfusion, they have a hyperperfusion, indicating that the clot has been removed spontaneously before the patient arrived to hospital, but still the neurological deficit is still there because it takes time for the brain to recover. So, of course, this means there is a major heterogeneity in the pathophysiology, and you need to understand what goes on in each patient in order to provide the appropriate treatment. Can you read? Yes, it's better on my screen. So the idea, was, which I defended in this paper, which was challenging the concept of the rigid and universal time window, which was the dogma at the time, is that depending on the profile of perfusion metabolism, you should adapt your treatment to that. So the clinical translation of all these studies, my work and work of others, of course, has been enormous. Revolutions, 1995, thrombolysis for ischemic stroke within 3 hours. 2008, thrombolysis up to 4.5 hours. However, thrombolysis only 30% we can analyze, so it's not good enough. Intra-arterial therapy with thrombolytic agents was shown to be beneficial in patients with penumbral small core. And then thrombectomy, which is to go with the catheter and remove manually clot, was shown to be beneficial up to 6 hours. All these are randomized clinical trials, international trials. And then up to 24 hours in highly selected patients with very strict criteria. And then the benefit of thrombolysis up to 9 hours in selected patients. And more recently, last year, this year, benefit of thrombectomy even in patients with large ischemic core. So, sorry, something was written down, but down here, but it's disappeared. Anyway, so there are a number of remaining issues, of course. That's my research to do. The first one is, can we prevent expansion of the core before thrombectomy? So, because it's a dynamic thing, if you can stop it before it grows too much, then it's a winning situation. The second issue is what we call futile recanalization. The problem that about 50% of successfully recanalized patients have poor outcome. And it's a problem because you do a very complicated treatment and the patient is not independent. Another problem is how healthy is the salvage penumbra. And finally, what is the effect of stroke on remote cortical areas, so-called Direskeneli? We go very quickly over these areas. The first one is, can we prevent expansion of the core before thrombectomy, which is going to freeze the penumbra? So this is the situation I described. The patient arrives at the hospital with a core and penumbra. 1.5 hours later, you remove the clot. Very good, but unfortunately, between the two, in this 1.5 hours, the core has grown, and therefore you have lost some opportunity. So the idea is the patient arrives at the hospital, you give some sort of therapy that freezes the penumbra, and therefore at the time of thrombectomy, the core is much smaller, and therefore the final infarct is smaller. You could even imagine starting the therapy, at home when the ambulance arrives, or in the ambulance, and you may know that now there are some mobile stroke units with a CT scan inside the ambulance, still partly research, but partly routine. Or you may start the treatment in the small community hospital before transferring, during the transfer of the patient to a thrombectomy capable center. So in these situations, you will, at the time of arrival to the hospital, the core will be even smaller, and you continue the treatment, and the infarct will be even smaller. and the outcome much better. Without recanalization, however, neuroprotection is unlikely to work. There have been dozens of trials which have cost billions of dollars in the last 40 years, and they have shown that without recanalization, it doesn't work. So you have to follow this approach. So there are pharmacological neuroprotectants that you could give, but so far none has worked. There's one which is being studied at the moment. The results have not been very good. Non-pharmacological approach may hold better outcome. Oxygen therapy, because the tissue is hypoxic. Remote ischemic conditioning to improve the electrodes, and spinopalatal ganglion stimulation also to dilate the brain vessels and improve blood flow. And this is the matter of lots of research at the moment. So now, futile recanalization, I told you these patients who do not recover sufficiently after successful thrombectomy. Now, many potential mechanisms. Re-occlusion, so you remove the clot, unfortunately the endothelium is damaged and the clot reforms. The core was too large at the moment you removed the clot, or the core affected areas for electricity, complications during the procedure, hemorrhagic transformation in the infarct, like parenchymal hematoma, severe vasogenic edema, which can be treated with hemicraniectomy. And another phenomenon which is quite interesting is incomplete microvascular perfusion, IMR, also called the non-flow phenomenon. We'll give you some words about the non-flow phenomenon, which was described in 1968 in the USA by a neuropathologist, I think. And the idea is that despite recanalization of the main artery, the capillaries remain blocked. So you can restore the perfusion or reopen the artery, let's say, but there is no perfusion in the tissue. So these studies were done in rabbits, but this was with global cerebral ischemia. At the time, there was no animal model of MCA occlusion with various durations. And what they did was infuse carbon black in the carotid arteries immediately or 30 minutes after sacrifice in order to fill in all the vessels, including the capillaries. So this is a carbon black image in the normal rabbit. This is a 5-minute ischemia. There's 12% of areas that you can see here and there where there is no capillary flow. And the longer the period of occlusion, the more extensive the low flow here, 93%. Again, this is like cardiac arrest. This is a global ischemia all around the neck. This, in short duration ischemia, you have this, it was like mottled. But here, it's the whole area which shows no capillary filling. So the model of MC occlusion was developed in 1966 at the Mayo Clinic, and these people from Harvard applied it to study neural flow, and this is an image of neural flow. This is again carbon black in the monkey, and you have all these regions which have no perfusion, despite recanalization. You can see it in the microscope. It was thought to be an intra-ischemic rather than post-ischemic process, with severity proportional to the duration, and it appeared to be due to extrinsic compression by vasogenic edema, compression of the capillaries, and could not be prevented by heparin. Further studies were done by Greg Del Zotto in baboons, 3-hour temporary occlusion, and they did electron microscopy. So, and they described the phenomenon of intravascular obstruction by neutrophils, leukocytes, which were from 40% of vessels. You have here an electron microscopy of the capillary with the leukocyte blocking, just a single leukocyte blocking the capillary. So there were lots of studies on neurological models. So there was not just leukocytes, but blood cells, platelets, in capillaries and venules. It's a very complicated literature. Target Dalkara from Ankara has done a very important studies showing pericyte contraction around the capillaries was also contributing to blood flow. What's important is that in preclinical models, animals, it can be prevented by various approaches, which are listed here. And therefore, it's important because this means it's important to study it for potentially to improve patient outcome after stroke. So the question is, does it exist in man? Probably it does, but it's important to document. Of course, post-mortem studies are essentially inadequate because there has not been a carbon black injection, so you don't know what's going on in the capillaries. And the best approach in vivo is to do perfusion mapping, like I showed with PET or MR or CT, because this assesses capillary perfusion. And what's important is that now with thrombectomy, you now have proof that you have actual recanalization because you do an arteriography after the end of the procedure. And here you have this occlusion here, and after removing the clot, you see the angiography, you have very nice filling of all the arteries and arterioles, but you don't know what's going on here in the capillaries. So, I mean, it's not easy to study because only patients with complete recanalization, what we call TK3, can be studied. Otherwise, if there are distal emboli, this will cause problems with perfusion. Reocclusion, as I said, would be a problem. And people with stenosis or occlusion in the neck, of course, will reduce perfusion. And hemorrhagic transformation in hematoma is a problem too. So there are very few clinical studies today that have assessed neural flow accounting for all these confounders. We did one of these studies. Unfortunately, the image doesn't appear here, which is the important image. I don't know why it is that. No, anyway, it doesn't matter. It's okay. No, it's okay. It's here. All right. So, I mean, we did a study with patients with complete reorganization, and we found only one case shown here. At 24 hours, this is MR perfusion, and you have this lack of perfusion here with an infarct which was not present initially. This is 24 hours. And however, this patient had no functional deficit at 3 months, so it did not explain futile recanalization. Recently did a systematic review of the literature, and using these criteria, we found only 2 studies, including ours, that properly assessed neural flow, and one was 0% and the other one 9%. So it seems to be a rare phenomenon in humans, but more studies are needed. Now, the salvage penumbra, you know, what we see after an infarction, I showed the images. At 3 months, you have this infarction. This is a CT scan at 1 month. This is what we call total infarction or pan necrosis. This is in a rat, and using immunohistochemistry with new N, which is a neural marker. And the question is, what about the salvage penumbra? How healthy is it? So we did studies in the rat using 45 minutes MC occlusion in spontaneously hypertensive rats. This is the perfusion during occlusion in one rat. This is autoradiography, so you see occlusions are very efficient. But despite this severe ischemia, 45 minutes occlusion, we had a pan necrosis only in one rat, and the other rats had what we call selective neuronal loss, which is these areas of neuronal loss, which you can see here, there. But this is not pan necrosis. It's just the neurons that have gone. And the degree of damage was proportional to the severity of hypoperfusion during ischemia. This I will skip. So we did a further model with, so that no rat would have pan necrosis or infarction, pure selective neuronal loss, which was 15 minutes, not 45. And you have here with immunofluorescence, very nice spots of selective neuronal loss. Here, there, was everywhere. And we showed that indeed this induced clinical, if you can say clinical behavioral deficit in those rats. A motor deficit of the paw, and which tended to recover, but we stopped at 4 weeks, but probably it would recover completely. But this does have clinical impact. So we studied non-ovarian hyperoxia. Does this prevent selective neuronal loss? With blended assessment, and you can see that during the 15 minutes, if you give oxygen, non-ovarian, you have essentially no selective neuronal loss and no behavioral effect. So this study shows that non-ovarian oxygen therapy could be very important to use in humans to freeze the penumbra, as we discussed earlier. Can we map selective neuronal loss in vivo? Yes, we can using PET and the marker of the GABAergic neurons or receptors, which is called fluorescein, with carbon 11. And this is in a baboon. It's a very old study that we did. And you see that with this marker, you see the loss of binding in the area of infarction, but also maybe the loss of binding in the cortex. However, this is the postmortem. However, it's very difficult to study selective neuronal loss in the geoencephalic brain because of all the sulfide and circumvolution and gyra. It's very difficult. So we studied it in the rat. So here we have the rat with pan necrosis, and here selective neuronal loss. Here we have partial necrosis. You see, it's just atrophic. And this marker, in vivo marker, is correlated with the degree of neuronal damage measured by mu n. Yes, I will finish. And you can see that in the rat, you can see this neuronal, selective neuronal loss with the mesonym and with the nice correlation. And we studied it in humans, and we can see it in patients with acute stroke and penumbra here. And at day 20, the patient has recovered thanks to thrombolysis, and you see no infarction in the cortex, only in the basal ganglia, but the flumazenine shows a marked decrease. So this documents selective neuronal loss exists in humans. It was present in 6 of 7 patients. In a further study, you can see it here very nice. So overall, it affects about half of the patients in the salvage penumbra, and it does impair neural activation using fMRI, but we found no clear effect on functional outcome, but not very gross markers. And we still don't know what causes this selective neuronal loss, but we think it's mainly ischemic neuronal death as shown by these correlations that I showed before, with several during ischemia. And in humans, the correlation, of course, is less significant, but there is a correlation here after a degree of damage. Okay, so we've also shown that in the areas of selective neuronal loss, you have a lot of inflammation, microglial activation, which is correlated between the two. And we showed this in the rat using PET and this marker. See at day 2, at day 14, you can see in vivo inflammation is visible. So this is something you can do in humans too. And this is OX42 in the same rat post-mortem. This very nice correlation. And in humans, we also did the study. You have here the mesonym and this marker of microglial activation, showing a lot of inflammation within the infarct, but very little in the salvage penumbra. And in fact, we found no evidence of inflammation in the salvage penumbra, which was very surprising to us. There are lots of studies using blockers of inflammation after stroke in humans, but based on this result, it's not clear if they're going to work or not. All right, thank you so much. Thank you very much for your attention.
Thank you very much for that presentation. Is there any question from the audience?
Professor, thank you for your.
Can you speak louder, please?
Professor, thank you for your speech. First of all, I have a small question. What can trigger those ischemic attacks? What can trigger those ischemic attacks?
What can
trigger?
What can trigger transient ischemic attack?
Yeah.
Well, it's exactly like I said for a stroke. It's the same. It can be embolic, a small clot. It can be a big clot. Also, transient ischemic attack can be very severe. It can be very mild. So it can be a clot coming from the heart, from the carotid artery or vertebral artery. It can be a local thrombosis, like people who have sclerotic plaque in the middle cerebral artery, for instance. There can be a thrombus that forms and that clears because it's transient ischemia. Or in the perforators, like I showed, striatocapsular small arterioles, perforators, with arteriolosclerosis, which is small vessel disease due to chronic hypertension, can cause, of course, it can cause mainly lacunar infarct, but it can also produce lacunar TAs. Yeah, and the last one is hemodynamic. Some people who have, like, for instance, an occlusion of the carotid artery in the neck due to plaque, atherosclerotic plaque, can occlude without causing major stroke. And then, if their circle of release is not very good, most people don't have a complete circle of release. Then, for instance, if they take anti-hypertensive medication and their blood pressure drops, so they stand up and they have a transient ischemic attack, or also in the retina. So these are the three main types of TAs. But it's exactly the same as a stroke, except that it's transient.
Thank you.
Thank you for your presentation. You mentioned that strategies that include freezing the penumbra before the recanalization is achieved helps reduce the size of the affected area from the infarct. And I was wondering how this freezing is achieved.
Well, as I said, in humans, there's no study or trial has shown that this works so far. Okay? But in the animal, many studies have shown it works. So it can be pharmacological with drugs various neuroprotectants that, for instance, block the NMDA receptor, for instance. And you have also non-pharmacological, which is like oxygen therapy, as I mentioned, sphenopalatine ganglion stimulation. So, of course, this seems very complicated, but it uses a small needle that can be, people say, easily inserted in the pellet to go to this small parasympathetic ganglion and stimulating it will dilate the blood vessels in the brain. And remote ischaemic. So there was also some paper about sphenopalatine, which is interesting because instead of putting a needle, you can put capsaicin, which is quite irritant, on the pellet. It must be very unpleasant, but and this does the same job. And what's called remote ischemic conditioning, which is to make the blood pressure go up and down, using a simple blood pressure cuff in the ambulance going to the hospital. But so far studies have not been positive. There's also hypothermia, but it's a very complicated thing to do because the patients, they don't tolerate hypothermia. But there are some studies which seem to be very interesting also with the hypothermia, oxygen, you can deliver not oxygen, but some agents, pharmacological, but they're not pharmacological, some carriers of oxygen intravenously that will carry oxygen to the ischemic area. So it's a huge area, not only in academia, but also in the industry, trying to develop devices and new approaches. There's a lot of future, I think.
Thank you, Professor.
Thanks for your presentation. My question is, it's unconditional, and when there is a total infarct at the coronary stroke, is it truly impossible to revive the tissue? Is it gone? I understand the nerves are dead, the cells are dead, but saying in the future, take a specific bath, salvage something from that tissue, something like data, information, or something else. I'm asking this question because there is interest in, reviving or replacing dead brain tissue, and many foundations are working on it. Things like, again, perhaps just replacing that tissue with regenerated nerve cells, or maybe even silicone chip-based things, or there are also things like cryotransformation, or that's different.
Well, nobody knows the future by definition. But you see, when I showed what we will pan in the process, there is no tissue left. How can you remake the cortex? Well, it's impossible. And some people have had crazy ideas, but they didn't work. Not only because it's impossible to recreate a cortex with all the layers and all the connections, which is extremely complicated, but also because around the lesion you have what we call a glial scar, which is almost impermeable. So I don't think this will work. But now there are other sorts of infarcts about impact from pan-necrosis, which is the classic one, as I showed. You have incomplete necrosis, which is, you have, it's not completely gone. You have some trabecular of tissue like that with white matter, bits of cortex. Maybe this is more amenable to, with stem cells to make some connections. So maybe the future will be that. And then you have what I showed, this selective neuronal loss, which is certainly available to treatment, but at the moment we're not sure it causes symptoms. It causes permanent symptoms. It seems to, because as you know, there is this phenomenon of plasticity, which is absolutely massive in the brain. A long time ago, people said that plasticity was only in children, and adolescents, but now we know it's completely wrong. Plasticity exists the whole life, even though it decreases. But so when you have, for instance, if you have a small infarct somewhere, usually the patients make complete recovery because the neurons around take over the functions. There is also takeover by other areas in the ipsilateral brain, even perhaps in the contra lesional brain. So you really need a significant area of tissue, the strategic part of the brain to cause permanent symptoms. So, but you're right. I mean, who knows?
Thank you.
Thank you for your presentation. I want to ask, what is the relationship, or is there a relationship between exofocal selective neural loss and the outcome of patient?
Between, sorry, selective neural loss and
exofocal. Exofocal.
Sorry, I can't get that one.
The selective neural loss and distal, and that occurs distal.
Neurovascularization.
On the actual side of the stroke, yes.
Neurovascularization.
Yes, but distal sides.
Distal.
Distal.
Can someone?
Distal.
Distal.
Yes.
Distal vessels.
No.
I'm sorry.
Exofocal.
Exofocal.
Yes, yes.
Oh.
Yes.
The relationship between neuronal loss and
Is
exofocal.
there a relationship between the formation of them and the outcome of patients?
Yes, yes. I mean, actually, it was the end of my talk, but I had to stop. It was too long. But yes, of course. when you have a lesion somewhere in the brain, with stroke or whatever, trauma, it has effects throughout the brain, yeah, by the connections. So the strongest effects, actually I can show you this example. This is a phenomenon that I described a long time ago, which is, you have a stroke on this middle cerebral artery territory, and what you see is a reduction of blood flow, oxygen consumption, and glucose consumption in the contralateral cerebellar hemisphere. So this is an effect of a lesion on connected areas through the cortico-pontocerebellar connection, which is excitatory. So if you have a lesion here, you lose excitatory input to the contralateral cerebellum, which causes this reduction of metabolism and blood flow as a consequence. So you have this effect. We showed also effect in patients with thalamic infarcts. You have this reduction in the glucose consumption in the whole cortex, even though this looks very small. It affects the thalamocortical pathways, and this can, this can recover, as you can see, and we have shown that this recovery of neural activity and synaptic activity underlies recovery of cognitive function after thalamic stroke. So yes, there is a whole field of whole literature of exofocal, as you said, effects after a stroke. Yeah.
It seems we don't have any much time, so we can proceed to the closing of the first session.
Thank you, Professor for sharing your long-time experience with us. Now I would like to invite my teammates, Elif Güher-Saruhan and Neurological.
Sorry.
This session was really interactive, and thank you all for your active participation. It's now time for a well-deserved lunch break. Our staff members are available to guide you to the dining area, and also you can refer to Matt if you want to go on your own. Please remember that your meal vouchers are inside of your name badges. Enjoy your meal, and we look forward to continuing with today's engaging discussions after the break. You will see a QR code that will be projected on the screen in a few minutes. Please scan it for the registration, and I will say the keywords. You can scan to fill the form. The keyboard is very aneurysm. Very aneurysm. Aneurysma in Turkish. I think we're done, so enjoy your meal. Thank you.
Hello, our esteemed guests. I'm pleased to welcome you all to the fourth session of the second International Neuroscience Days. Today, we welcome you to our session focusing on the genes in the understanding of multiple sclerosis and associated diseases in the last quarter century. Our aim in organizing this session is to open modest highlights for you, our esteemed participants, in neurological research and shed light on future treatment strategies. The introduction by Professor Dr. Aksel from Cerrahpaşa Faculty of Medicine will share one-of-a-kind viewpoint on the relationship between multiple sclerosis and other diseases, giving us modern mix of knowledge. Professor Dr. Aksel from Cerrahpaşa Faculty of Medicine will engage us with insights of neurological development and degeneration. Let me conclude my sentences by expressing gratitude towards Professor Dr. Siva for attendance and for sharing his expertise and insights with us today. I moreover need to thank each of our groups and onlookers for taking part in this congress. I hope you are looking forward to the session as much as I am. Now I leave the floor to our first speaker, Professor Dr. Aksel.
Dear chairs, dear colleagues, dear guests, I should start saying, well, first of all, thanks for this kind invitation. And I should admit that I'm full of joy because this room is young, very young. It was about half a century ago when I was a student. Well, as you see, I have aged, but my student feelings remain young. So now I'll take you through a journey of what had happened in the last, let's say now 30 plus years in MS. MS is, you know, the disease of the young, but I think it's been the most rewarding chronic disease in neurology within this last quarter of century because of the developments we had. When I started to work in the field of MS, which was the mid-80s, there was no treatment. We didn't know much about MS. And from the time of Charcot, when the disease was first described as sclerosing plaque, not much had changed. And nobody in neurology wanted to do MS. Somehow I happened to go in that field. And for many, many years, in the whole country, were only 5 people, 4 ladies and myself, named Aksel from Aksel, Egemen Diman from İzmir Kuzeyli University, Rana Karadağ from Hacettepe, and Ceylan from again, Ankara. No one else was much interested in multiple sclerosis. Now today everyone wants to do MS. Anyway, now let's start my presentation. These are my disclosures. And the outline of the talk, I'll start by, actually the first couple of slides will be the whole summary, actually, the core of my talk. What we knew by then and what do we know today about MS, the diagnostic criteria, the evolving concepts, the emergence of the radiologically isolated syndrome, which I will emphasize a little bit because we have been, as the Cerrahpaşa Neurology Group, a part of this story, and the clinical phenotypes, the spectrum, how it changed, the biomarkers, and so on. So, let's say, why the last 25, 30 years? Because the first MS drug was introduced in 1993 in the US, and then 1995 in Europe, and then in our country. And this was interferon beta 1 be the first MS drug, long-term treatment. But is it really that time, before time, after time, in the timeline of MS? Quite possibly. Not only because we have a measure of control over the disease progression, altering the future prognosis for many patients, but also with the introduction of disease-modifying treatments and associated research, especially MRI studies, over this period of time, we have learned much, much more than what we have learned since the era of shock. So, what we used to know in the 1990s about MS, just let's say before the turn of the millennium, and what do we know today? MS is a rare disease. That's what we thought. Today we know that it's not such a rare disease. It's a white man disease. That's how we knew. Many textbooks still probably as MS as such. But now we know that it's a whole, actually not brain, spine, the whole CNS disorder. It's a neuroinflammatory demyelinating disease. That's also wrong, or it's not explaining everything. MS is a neuroinflammatory and neurodegenerative central nervous system disease. Initially, it's a relapsing multifocal disease of the CNS. While it's more likely to be an ongoing diffuse CNS disease from the onset. Most MS patients will develop clinically progressive disease. That's what we used to know. Today, we know that only some MS patients will develop clinically progressive disease. This may sound a little bit paradox with what I will be saying in the next slide, but we'll go to that later on. Now, let's briefly mention the rare disease. It's still rare, but not as rare as we thought it was. And this is the MS Atlas, which was updated just recently. And you see the dark red is where it is more common, which means it's more than 100 per 100,000. And then you go through the colors, tissue search. And you will see that our country is in orange, so it's between 50 and 100 per 100,000. Actually, in the early 2000s, when the first MS epidemiology studies came in Turkey, what we have reported by them was a rate of 30 to 50 prevalence rate per 100,000. But and I should mention that now in the whole world, MS had increased both the incidence and prevalence, and it's almost doubled. How come? Why? Number one is awareness, increased awareness. And now we have, the house doctor, Dr. Google. So everyone who starts to have any symptom, they go on the internet, they ask for Dr. Google what they might have. And since in MS, we know that many CNS symptoms may be related, which doesn't mean that it is MS. Well, Dr. Google will mention as one of the possibility MS. So by the time they go to the doctor, they say, hey doc, I have MS. Anyone may certainly do not have. But this had really increased awareness of MS. When we have started the Turkish MS Society in 1988, no one in our country, almost no one, knew what MS was. I mean, the lay people. But even many doctors didn't know much about it. And today, everyone knows, at least they know that it's a nervous system disease. So that's not only but it's about one of the number one reasons why MS had increased enormously, I should say. But the second one is probably the developments in healthcare. People can reach healthcare institutions, clinics, and so on, much more. Can have more work, more MRI studies, and so on. And that will actually show many cases who probably would go mild and that they would never know that they had MS in their lifetime. So, and there's certainly a real increase in immune-mediated diseases. This paper was recently published about a month ago, and it's the real number first, the whole Turkish MS epidemiology study, which was actually a beginner's trip from Cerrahpaşa. He led this study, and we all have contributed to it. It's just based on the health records of the Ministry of Health. And it clearly shows that it's almost 100 per 100,000 in Turkey, double of what it was 20 years ago, or at least we knew. The female-male ratio, as you see, is 2 to 1 in our country, and the mean age at the time of diagnosis is around 34. Let's go on what we used to know and what do we know today. Axonal degeneration is a secondary phenomenon to demyelination. That's wrong, very wrong. Axonal degeneration is not a secondary phenomenon, it's primary as well. Myelin is was considered to be the single soprano stage. That's also wrong. Oligos, microglia, astrocyte, pericytes, they are all involved. The whole CNS is there. But still today, when you will look in many words, you will see that it's a myelin disease. And I don't really understand. I'm a clinician, I should admit that. And my presentation is a presentation of a clinician, not a basic scientist. But myelin is only part of the story. Maybe it's one of the most vulnerable structures within the CNS, and it is, we see the damage more there, but that's not the whole story. It's not a sole myelin disease. And as we started to learn immunology, we thought that it's the MS was the T-cell mediated immunity, but today we know well that the B-cell takes the forefront as well. And experimental allergic encephalomyelitis is the animal model of MS. And this is something I haven't been able to understand over the last 50 years, let's say, that I have been involved, well, not 50 years, but the many decades. I don't understand how come EAE is still considered to be the best MS model, because it is not. We know, I will later on mention about a disease, MOGAD, mold-associated disorders, which is thought to be at the before part of the MS spectrum, but we know that it's a different disease. It's a IgG, myelin oligodendrocyte glycoprotein antibodies related disorder, and it's not MS. And EAE model is maybe the best model that could explain that disease, but not MS. But still, and when I discussed this issue with my basic scientist colleagues working in the field using the EAE model, well, what they say is, yes, you're right, but that's the best that we have today. But if you work with the wrong model, I don't understand how you can get correct answers. And this is just to give you an idea that over the last maybe 10, 20 years, we have it's not that they didn't exist or they. It's only now that we have started to look and then find that all these cells are really playing a role in MS. And actually today, maybe one of the most important cells that we talk on, we discuss in MS is microglia, because it is all considered by all that microglia is closely related with progression, with the progression of the disease. Astrocytes as well. Probably now we have just started to look in the pericytes, and then we find that they do have some responsibility in the pathogenesis of the disease. And also we have learned that there's the good microglia, the bad microglia, the pro-inflammatory, anti-inflammatory functions. The same goes with astrocytes. So it's pretty complicated, but we're learning. And this is a nice paper. It's not very new. It's 2009. And I know well Israel Steiner, and I won't go. It's a story until this paper was published in the Annals of Neurology, which is one of the most ranked clinical neurology journals, or neurology journals, let's say. And here they describe, maybe they would rewrite this paper today, they would have a stronger hand to say this. Yes, what actually Charcot had mentioned at his time, there is discordance between clinical and pathological findings in MS. And yes, that is correct. We only know that there is discordance in the biology, immunology, imaging, pathology, and clinical phenotypes in MS and beyond. It is a very heterogeneous disease, and there are not only clinical phenotypes that are different, there are pathological phenotypes that are different, immunologic reactions, so we are still learning. And the clinical expression does not always exhibit consistency with the histopathological immunological phenotypes, and overlaps are not uncommon. So when we are talking of MS, we have to keep this in mind. And this is why it is so important that we are not talking of a disease when we see someone with MS, but we are talking of someone who has MS. So it's the individual who has the disease. It's not the same with others. And this is why personalized or individualized medicine is so important, especially in the field of MS. Well, we knew that MS actually is an ongoing lifetime disease. Well, today we know that for most people with MS, it's an age dependent in most people. And I'll come back to this later on during my talk when I will go over some of these concepts in more details. Well, at that time we were unfortunate. We would say that unfortunately we cannot change the natural history of MS. But today, even if we cannot change, we can modify. Our hands are stronger today. Well, at that time, there were no prognostic predictors. It was just the gut feeling. And the gut feeling is still very important. To me, it's still. I won't have time to discuss about artificial intelligence in medicine and in the field of neurology. That was a talk I gave about a year ago in an international meeting. But I would like to discuss this with you as well. Because that's the future that we should be aware of. There are prognostic predictors, mainly imaging fluid or liquid biomarkers today. And unfortunately, in those times, we say that there was no treatment for it, but now there are some treatments. We have no idea about genetics in this. Now we do have some clues. And the coming years, I'm sure we'll be able to say much more. Now let's go in some of these concepts in details. The first, well, there have been some other MS diagnostic criteria before the Schumacher committee at all, but Schumacher et al., the committee he led, and that was the basic concept that MS is a clinical disease, central nervous system disease disseminated in time and space. And this is still out of the story today of those diagnostic criteria. So what do we mean by that? It's lesions, well, let's say inflammatory demyelinating lesions occurring in different sites of the CNS at different times. And if we can show this and exclude all other possibilities, then we would make a diagnosis of multiple sclerosis. And until the millennium, this was based on clinical history and examination. Only in 1983, the old late Charles Poser from Boston, the committee he led, wrote the famous Poser criteria. At that time, MRI was just in its first years, so it was not really included in the diagnostic criteria. But we had, for the first time, CSF, evoked potentials, and to rule out CT as imaging modality as paraclinical evidence to make a diagnosis. Then the McDonald criteria story had started by 2001, which was actually an MRI-based diagnostic criteria. And at that time, we could make a diagnosis of multiple sclerosis on the first episode if the criteria was fulfilled. But the rapid developments in the field of MS, as I have mentioned, urged the committee to revise the diagnostic criteria, and this was done in 2005, 2010, 2017, and the new revision will come out probably later this year, but I will tell you what is going to be in it later on. So these are all these criteria over the years, and with every new revision, we saw that MRI became more and more dominant in making a diagnosis. So I won't go in details, but again, to mention if someone experienced two separate attacks separated by at least CNS episodes by 1 month, lasting more than 1 day, but in real life, forget about this time limits. But that's according to the criteria, at least 24 hours apart. Second, in order to say a second relapse, it has to be at least 1 month in between the two attacks in different parts of the central nervous system. The old Poser criteria is still valid. But in many people, this won't be possible, but now MRI will replace it. And for progressive disease, you need at least a progressive neurological deficit that goes over a year and cannot be explained by any other possibility, and maybe also needs to have the MRI for and/or CSF criteria. So the dissemination in time and dissemination in space concepts makes the McDonald criteria. And what is this? So the dissemination in space is when you do an MRI in someone who presents with a CNS episode, and MS is one of the considerations. And the MRI will show one or more lesions in one of those 4 sites where are the periventrically, juxtacortical or cortical, posterior fossa, and the spinal cord, then the dissemination in space criteria is fulfilled. But you also need dissemination in time criteria, and this is done if you have one enhancing contrast filling lesion and a non-enhancing lesion in the same MRI, this will fulfill the dissemination in time, because the contrast enhancing lesion is a new one and the other one is an old one, the non-enhancing lesions. So you can fulfill the time, dissemination in time. But if you don't have an enhancing lesion, then this will be the time criteria will be replaced by showing oligoclonal bands in the central spinal fluid of these people. So for relapsing MS, one single attack consisted with inflammatory demyelinating lesions suggestive of MS. MRI criteria fulfilling dissemination in time and space, and in the absence of dissemination in time, as mentioned, CSF oligoclonal band positivity will confirm. For primary progressive MS, 1 year of disability progression, dissemination in space criteria should include at least one spinal cord lesion, and again, you need CSF oligoclonal bands. So, as I have again just said, in later this year, the 2024 revision will be published, but we know already what is in it. So what I will be talking on radiologically isolated syndrome has made it its way to the new criteria set. So this subclinical phenotype for the first time will be included in this new MS criteria set. And we'll be talking about it. And MRI-related proposals are, again, MRI, as I have said, is very dominant in the criteria. Now, dissemination in time, we have a fifth site, which is the optic nerve. So the lesion, again, 2 lesions, at least, one or more lesions in at least 2 of the 5. So yes, it was 2 of the 4, now it's 2 of the 5. The central band sign will be implemented, as well as paramagnetic rim lesions. I will tell you what these are later on. We have also the biomarkers, the OCT, and the CSF oligoclonal band is still having its strong hand, but now it has also an alternative, the kappa free line chain. And additional criteria has been now introduced for people with primary progressive MS, for pediatric onset MS, and primary progressive MS. How the MS spectrum has evolved. So this is from a chapter that we wrote with Orhan Kantarcı, my longtime co-worker. And we wrote this chapter for a MS group years ago. But I should mention that Orhan currently is a professor of neurology at Mayo Clinic in Rochester, Minnesota. When he was from graduate of our English medical school, Cerrahpaşa English program. He was very bright. Well, he's still very bright. And for whom I met him when he was a second grade student. And since then, we have been working with him. So when he completed his residency with me, I sent him to work with Brian Weinschenker at Mayo Clinic. And then he was so successful that they wanted to keep him there. So he did a second time residency there, and now he's the professor working actively in the field of MS, and we continue our collaboration. So it was very simple at that time. Today, it's much more complicated. So we have the MS phenotypes, which are subclinical and clinical. So we have asymptomatic MS, pre-RIS, radiologically isolated syndrome, RIS, clinically and so on. And we have the MS variants, the solitary sclerosis, myelocortical. I'm sure you won't remember those, but just to give you an idea, we have the MS variants, and then we have the other atypical inflammatory demyelinating diseases, which once upon a time ago, it was a part of MS. It was only after the millennium that now there are separate diseases. And this is acute disseminated encephalomyelitis. Some are seronegative, some are seropositive, MOGAD. NMO spectrum disorders, MOG-associated disorders, relapsing idiopathic optic neuritis, the Rion and Prion, and other antibodies, non-disease related diseases of the CNS, and some seronegative ones, which probably will, their antibody will be discovered in this coming years. And now when we look in those two these major groups, we see that the first two are more likely to have a neuroinflammatory neurodegenerative component together, whereas the atypical group is more likely to have a neuroinflammatory force with relapsing phenotypes, whereas the first one is both relapsing and progressive. And as a personal approach, you can also look in those disorders as seronegative central nervous system diseases and seropositive. And what do I mean by that? The seronegative ones, for now, I should emphasize, because we may be able to find new antibodies for those in the future. MS spectrum, the double plus seronegative NMO spectrum disorder, CNS involvement in autoimmune, autoinflammatory systemic diseases such as Bechdel syndrome, and the CNS involvement in generic autoinflammatory systemic diseases such as FMF and TRAPS. But when we look in the now seropositive ones, we see NMO spectrum, MOGAD, other antibody-associated disorders, paraneoplastic disorders, and CNS involvement in autoimmune systemic diseases such as SLE and so on. Well, recognizing the asymptomatic subclinical phenotype of MS, the initial footsteps of radiologically isolated syndrome. Yes, what we used to know in the 50s, 60s, 70s, there was some people who had subclinical disease or asymptomatic MS. And what we meant by that, when clinically silent disease was diagnosed by chance, mainly at the beginning at autopsies, and later by neuroimaging, or biologically by the CSF studies and other findings, in people who never had symptoms or signs of multiple sclerosis. Well, we knew, and especially autopsy studies had shown that there was such a population. So in the 2000, we started to see this via MRI. And therefore, and later on came the radiologically isolated syndrome. I have mentioned that we have contributed to this. And these two papers later published in 2008 and 2009 by the French MS group and by our center in the 2007 American Academy of Neurology meeting. We both had a poster, and we exactly mentioned the same thing. Yes, there were some people who described asymptomatic MS lesions in people who had, let's say, who were admitted for headaches, migraine, and turned out to have this kind of lesions. But none of that followed these people to see what had happened and what were their characteristics. but the French group, and we did so. And both of our posters were chosen to highlights at that year. And the following year, the UCSF group, the Rinokuda and his colleague Sterin was a fellow at that time, and they have described exactly the same thing again at the AM. And they named, the name they gave actually became the terminology for this symptomatic MS discovered by incidental lesions by MRI. So Orban and myself, Orban was also on our paper. Orban, in 2009, when Darren had another presentation at that year's AM meeting, he said, let's meet with the other two groups, the French group and the UCSF group, and see if we could do anything together. So after Darren's presentation, we just waited. Christine Lebrun from NIST, who we now call Sister, and Christine came out. We just introduced ourselves, and we knew each other by our names because of our works, and then Darren came out. And then in 2009, we have founded the Radiological Isolated Syndrome Consortium. And over the years, I will just skip the Okuda criteria. It's not very important. Over the years, we have published a great deal in them. At the beginning, it was rejected. It was not accepted. We had difficulties to publish, 3 of us, our papers, but they all end up in good journals. And then the neurological community started to accept, let's say, this. At the beginning, they say, you are just talking bullshit. You're talking with people who have just some P2 lesions in their eyes that has nothing to do with that. But they learned that this was not the case. So, and then we have, there have been other centers all over the world who contributed to our work, who work with us. And we have published altogether a number of breakthrough papers, I should say, and have shown that at 5 years, about 1/3 of these people in whom they would have an MRI study for...
Excuse me, Professor. We have 15 minutes left.
Oh, I'm just at the beginning of my talk. Anyway, I'll try to speed up, but actually, yes, the people with incidental lesions, but they couldn't be explained otherwise, so we started to follow this. We have shown the risk factors, and at 10 years, we have published that about half of these people would convert to clinical disease. And if they had lesions in their spinal cord, posterior fossa, if they had oligoclonal and so on, the risk of converting to multiple sclerosis would increase. Last year, we have updated the RIS criteria, and now we know that RIS, it's a diagnosis, it's the earliest phase of MS, it's a subclinical disease phenotype, and it's a warning to the MS, to the neurologist, to the MS experts, and might be a game changer, because from the times where we were discussing whether we should consider treatment to this phenotype, in the last 2 years, we have published 2 major papers showing that treatment was significantly delaying the first clinical event in these people, and now it's going to be considered as a part of the treatment spectrum. When we look to the clinical phenotypes, again, what we knew before the millennium, it was MS was relapsing, remitting MS, primary, progressive, secondary, progressive, progressive relapsing MS. But today, it's mostly now relapsing or progressive disease active or non-active disease, stable or not stable disease. And this is mainly based on the either clinical relapses or having new lesions on the MRI. And this is also what makes us making a treatment decision. So this is what, if we look in the natural course of MS, now we have radiologically isolated syndrome, discovered by chance, and we know that about half of these people will convert to clinical disease, which then will be either clinically isolated syndrome if they don't fulfill the Markov criteria, but if they do fulfill, then it is single attack MS. And of those, depending on their admitting features, about 40 to 80% will convert to relapsing remitting disease. And then of those, again, some will convert to secondary progressive disease. We know that about 12 to 13% of the MS clinical population actually has a primary progressive MS, a progressive disease phenotype from the very beginning. But maybe if we think, and we have shown this in one of our NIX papers, that it is likely that some patients with primary progressive MS, in fact, go through the other clinically isolated syndrome, relapsing, remitting stages of the disease without any symptom and signs, and that the disease becomes clinically significant only after the critical threshold of axonal and myelin loss is reached. And this was one of our papers, again published in 2016 in Annals, showing that some of the people from radiologically isolated syndrome, they didn't, when they converted to MS, it was not a single episode, it was primary progressive. So, and we knew that these people continued to have new lesions during the silent period of their disease. So, yes, probably primary and secondary are artificial concept, but it's higher progressive disease. And we know that, as I have mentioned, reaching a critical threshold, and that is how we explain this, there's the brain reserve. And so it is important to consider treatment before the brain and spinal cord reserves are worn out. And when we look at the relapsing phenotypes, risk going to MS, relapsing MS, single attack MS, relapsing remitting, relapsing progressive, and then the progressive phenotypes. Actually, again, in the last 5-6 years now, we have started to talk of silent progression in MS, progression independent of relapse activity in the last couple of years, is called PIRA and transitional. So we know that even people who have relapsing remitting MS, when they come 10 years later, they have accumulated some disability, although not much. So this means that they have progressed very gradually, very slowly over the years. And therefore, this is called silent progression. And we know that people who have progressive disease are either relapse-associated progression or progression since onset. So let's ask the question, are all clinical MS phenotypes progressive? So what we know today is that all individuals with MS, subclinical, clinical, have progressive features, but that doesn't mean that clinically they will have progression. The clinical forms of progression may be seen as non-relapsing progression, progression over PIRA and so on. And in a person with MS, these progressive phenotypes, clinical behavior can emerge either as a single entity or in combination. However, progression does not manifest in the clinic in the same way for all individuals with MS. It might not be clinically determined or observed in many. And the clinical expression of progression carries individual characteristics, blending in varying proportions with genetic and environmental factors, and may not reach a noticeable level or remain asymptomatic in many people with MS during their lifetime. So please keep in mind that MS immunopathogenesis is not equal to the MS clinical expression. So what is the current understanding? So due to the time limits, I won't go in details, but what we know today is when we study these people in the radiologically isolated syndrome, or let's say asymptomatic era, you see that they do have some atrophy in the thalami, in the gray matter, in other parts of the brain. There are ongoing activity, although that we don't see the clinical expression of those. So, and over the years, this continues, whether they develop clinical disease or not. So probably now today, it's more important to discuss of MS of a continuum, a relapsing, which may remain as such for many, but also progressive in some who the behavior will not, let's say, immunogenetic phenotype will not be able to suppress the disease progression. So today now we are talking of a continuing, and this might be a part of the biopathology, how it evolves, and when it's age dependent, I should say. So we know that in young people, MS treatments are very effective, but not so much later on. The age of the disease, the duration of the disease, at the beginning, it is much more responsive to treatments. And later on, we know that with the age factor, both the neuroinflammation and the MRI activity and everything else slows down, but the degeneration will go on. And maybe my co-worker, so an associate professor now here in neurology, he also spent the year with Orhun, and you see that in our paper here, based on the Mayo patients, which I had gone through their trials some 20 years ago, and that's why I'm on this. The all progressive phase in an age-dependent story. But despite all these observations and that data, it is clear that in some people with MS, the disease may increase at one point. We should not forget this. And this may be even before the clinical onset. So these are people with RIS who won't convert to clinical disease.
Could you please sum up those sentences?
I need a little bit more time, okay? Although that the progression may be detected in some individuals with MS, with some sophisticated tools, this may not be expressed always clinically. So we need to keep in mind that the underlying and detected pathogenetic changes may not always have the same corresponding clinical expression in all individuals with MS, and MS is a highly personalized disease. So age is an important factor today in understanding multiple sclerosis. And now we have started to talk of biological age and chronological age. And so we know that some people whose biological age is maybe more advanced than their chronological age are doing worse than their counterparts whose biological age remains younger. And today, it's new studies, and we are involved in our center with the telomere studies where we can show the difference between biological and chronological age in MS. I'll go very quickly through the biomarkers. We have the imaging biomarkers. These are MRI, OCT, and PET studies. We have the liquid or fluid biomarkers, the oligoclonal bands, neurofilament light, gliofibrillar elastic proteins, and many others, and the genetic ones. None are diagnostic, and definite prognostic, but they do have predictive values when we come to imaging biomarkers, and this also helps to improve our MRI diagnosis of MS. So we know that the MS lesions have a vein passing through. So the central vein sign, again, which has been now probably described in the last 7 years, is, as you have seen, had already found its way to new diagnostic criteria. The iron ring, the paramagnetic ring, which is seen around chronic smoldering lesions, let's say, and the cortical lesions, which, especially if you do 7 Tesla MRIs, you will see that people with MS have a lot of cortical lesions. And this is not really seen in many other diseases. But certainly these MRI features requires high-field MRIs and very sophisticated studies, and therefore currently they are not very practical. Just to show you, this is how a lesion goes through a MS lesion. And if someone has around 40 to 50% central vein sign in their lesions, this is almost pathognomonic for multiple sclerosis. And also chronic lesions tend to have an iron ring around them, which is actually a marker of ongoing silent progression or low-grade inflammation, and is associated with the disease, disability, and progressive disease. Also, in the last few years, we have started to talk about choroid plexus inflammation. So if someone with MS have a large inflammation, this might be a sign of progressive disease for the future, and therefore we should maybe consider more stronger treatments. The same goes with what I have had most of them, not all to have iron leaf, but slowly expanding lesion, which means that you have an MRI, you show a lesion, and on the follow-up MRI, a year or 2 later, you see that this is growing. So that's not a good sign really, and it may mean progressive disease. And so this is again another clue that you should treat these people with the strongest therapies you have. So this is what we call the smoldering lesions, and which became a part of the current. In the last few years now, we are keep talking of smoldering lesions, and this is the type of an ongoing low-grade chronic inflammation that occurs in MS and is correlated with disability. So these are really highly significant, but in real life today, they are not practical. However, in the near future, artificial intelligence will replace, had already started to replace the radiologist, the neuroradiologist, and you will already have a report in your hands showing that this patient had this many lesions with central vein sign, that many paramagnetic ring sign and so on, and that you will be able to know much more than you do today. And also, optical coherence tomography is also a biomarker and it's correlated with the diagnosis and prognosis of the disease. The fluid biomarkers of those today, neurofilament light is very important, a biomarker specific for neuroaxonal damage and EPA, Glial fibrillary acidic protein, a biomarker of astrocytic damage. However, it's, well, you can certainly measure this with the LITSA in the CSF, but in fact, it's not practical to do a spinal tap every time to follow these people. But now there's a new methodology, Siva, and you can measure these biomarkers in the serum. Our faculty, the Cerrahpaşa Neuroscience Institute has the first Simoma machine in Turkey, and now they are almost completing their validation studies, and soon we'll be able to look in the serum in our patients. Skip those, so it was the, and we know that the neurofilament light, if you find it high, it means that it's ongoing disease activity, neuroaxonal damage, so it's, you see it's axonal damage, and renal fibrillary acidic protein GFAP is associated damage marker. So if you show that these are elevated, this will correspond to ongoing clinical activity and mainly GFAP with the progressive disease. So you have again to make your treatment decisions accordingly. Genetics, we used to know very little or nothing at all before the millennium. Today we know much more, but still not enough. And the familial risk, it's also, knowing this will tell us maybe more in the future. And our group again is leading the Turkish MS genetic, familial MS genetic studies. And together with NIH in Bethesda, we continue our studies. So we have families where like one family where they have 7 members with multiple sclerosis, many families with 5 members or 4 members in the family. And we believe that this is going to tell us more in the future. And then recently there was a gene, or not gene actually, a locus Direskeneli, which was associated with more progressive disease. So we are just, will be learning more in the near future. Microbiota, both in the gut and in the lungs, are currently studied in MS, but we certainly don't know exactly. EBV infection in the last years in MS has been associated. There are some people who think that EBV is the cause of MS, and I don't think so. It might be a facilitator, but it's certainly not the cause. So, once upon a time ago, all were MS, but there are now diseases that are not MS. And David syndrome, neuromyelitis optica, has been shown that by the Mayo Group, by Brian von Schenker, who I just mentioned his name earlier, that they do have a specific antibody aquaporin for IgG. So it's not MS. It has its own clinical phenotypes. It's all a relapsing disease, but very severe. And it is just relapsing, very severe. It may be fatal, but now today, again, the first one was, I think, approved 2019. Then we have 3 drugs which are very effective in neuromyelitis optica. And then by the time that the 2015 diagnostic criteria was the new one for NMO, it became already out-fashioned or outdated, because at that time we have learned that there are another group which looks very like NMO, which are associated with MOG antibodies. So now we have the MOGAT, and the MOGAT diagnostic criteria has also been recently, last year, published. So the same goes with optic neuritis. There are different types of optic neuritis, so not all are related to multiple sclerosis, and you see there's a list. So if we start looking, we start to see that they are not all the same, but quite different. And finally, when we come to the treatments, in the last 25, 30 years, we had more and more treatments and more upcoming. We have no time to go over those, but from 30 to 40% effectiveness, now we have drugs that works in 80% of the people. And the treatment approaches has modified accordingly. So there are still maybe some benign cases where we may not treat at all. but there are escalation, induction, or rather personalized treatments for MS. There are first-line therapies, intermediate, induction, more stronger, and the most strong treatments, which are generally monoclonal antibodies. So certainly not all MS treatments are medical. There are also assisted devices and mainly the robotic developments, the exoskeletons, the brain computer interface. These are really, again, the future. So when making a treatment decisions, however, I'll come to the very beginning. Let's keep in mind that we are not treating just the disease, just the label, but the individual with the disease on site. And we know that when making treatment decisions, one should keep in mind that not all people are created equally, biologically equal, and this is the same case with multiple sclerosis. So treating MS and treating or not treating MS or how to treat has lots of different colors. And finally, finish. Thank you.
Thank you very much, Professor Siva, for your well-defined presentation. Now, we continue with the second talk, and because we exceeded our time, the question sections will be at the end of this section. We are thankful to Aksel for his illuminating presentation.
Sure.
I will present the testimony to my colleagues, Güher-Saruhan, who will present our sort of appreciation to Aksel Siva.
Bir dakika. Çok özür dilerim. Teşekkürler.
Our next speaker is Professor Dr. Güher-Saruhan, Direskeneli, Prof. Istanbul University. Today, we welcome you to our session focusing on the autoimmune response and potential targets in Myasthenia Gravis. Our aim in organizing this session is to open modern skylines for you, our esteemed participants, in neurological research and shed light on the future treatment strategies. The introduction by Professor Dr. Güher-Saruhan from Istanbul University will share one of a kind viewpoint on the relationship between Myasthenia Gravis and autoimmune system, giving us modern bits of knowledge. As I conclude, I extend my much appreciation to Professor Direskeneli for making this session commendable and everyone participating in this important knowledge-sharing platform. I wish you all a beneficial session. Thank you.
Hello everybody, so nice to see so many people at that time of today, at the second day of this meeting. I'm sorry for sitting here because I need to point out with the pointer in my presentation. So I need to use the pointer, so I prefer to sit. I'm sorry for the people that I cannot see. But it's a very, very nice surprise for me to be invited to this meeting because I'm working in immunology mainly. I'm a basic scientist, and I'm actually kind of out of context here for the neuroscience. And immunology is a big area for my understanding as a whole. And I will try to introduce you to immunology. As you all are familiar with the immunology, I hope, we will have a different aspect, a different area to look at today. I'm really, I thank the organizers again for the invitation, and I will try to do my best. So I am an immunology person, as I said, and myasthenia gravis is a very interesting disease for an immunologist. It is a prototypic disease of autoimmune diseases because it has features that are very well filling the criteria for being an autoimmune disease. Autoimmune disease in general, meaning that the immune system targets the own body, as you know. And there are some criteria that are considered for the definition of autoimmune diseases, and these criteria are almost all are fulfilled by the myasthenia gravis. Although it's a rare disease in general, it has specific features, as I have summarized here in the slide. The autoantigens that we call are the molecules that the immune system is actually targeting. And the targets of the autoimmune response are defined in myasthenia. There are two main antigens, and two of them, acetylcholine receptor and the muscle-specific kinase, are the main antigens. And these are already shown and are the targets. And they are inducing the disease with that response against this molecule. The second autoimmune feature of myasthenia is the presence of autoantibodies, meaning that this immune system reacting against these antigens. And these antigens these antibodies that are produced in the system are mainly T-cell dependent, are produced by a T-cell dependent procedure. And they are all IgG subclass of the antibodies. Because the IgG is a secondary response product in general, we understand this is a kind of antibody production that is produced by B cells, but with the help of the T cells. So we understand both cell groups are involved. So we have to deal with both of them. And another feature of the myasthenia is the thymic changes in the thymus tissue. As you may remember, the thymus is the primary lymphoid tissue where the T cells develop and where T cells are selected and generated and selected, let's say. And thymic changes are frequently together with myasthenia gravis. There are different kinds of changes. Not all myasthenics have the same changes in the thymus. And you can observe inflammation, hyperplasia, and sometimes thymoma, which is a tumor of the thymic tissue. And it can also, but myasthenia can also be observed with the involution of the thymic tissue, which shows us the thymus is somehow involved, but it can be involved in different forms. And we don't understand what kind of contribution thymus might have in the development of the disease. And lastly, the genetic susceptibility of the myasthenia, which is actually a kind of common feature of the autoimmune diseases, is also present in the myasthenia case because there are many genetic association studies. HLA association which is a common feature again of the autoimmune diseases, like in MS, for instance, used to be one of the markers. And again, the myasthenia has been shown to be associated with different HLA alleles or antigens. And there are also some subtypes that are not associated with the same genetic markers. So it also gives us, again, a variety of disease forms, and we understand that the autoimmune features of the myasthenia can be different in different subtypes, and it is a nice opportunity to actually study these differences, which may lead similar clinical features. So, if you look at the immunology of the myasthenia a bit in more detail, as you see here, this is a neuromuscular junction where the nerve ends at the muscle membrane. The nerve terminal releasing the transmitter, the acetylcholine, is actually inducing the signal at the muscle membrane. And the signal will be taken by the receptors which are on the muscle membrane, which are called the acetylcholine receptors. And with that signal, the signal from this nerve terminal will be transmitted to the muscle, as you know. And this receptor here is a specific molecule with a feature that will actually turn to a channel if it binds a ligand. It is a kind of ligand-associated channel protein. And this is actually the function of, this is very important for the function of the neuromuscular junction, as you can imagine. Next to it, there are some other proteins again on the muscle cell membrane. As you see here, MUSC, which is the muscle-specific kinase, which I mentioned, is another membrane, another protein on the cell membrane, on the muscle cell membrane. And there are LRP4 and agrin that are interacting with muscle protein. And agrin is again a protein, a signal molecule from the nerve terminal. When agrin is actually in the vicinity, then the agrin, LRP4, and a muscle protein all together interact, as you see here. And the signal will again be introduced into the muscle cell. And this signal actually helps the acetylcholine receptor to cluster, as you see here, to come together, so that the signal can be transmitted more easily. So if the muscle protein is somehow related to acetylcholine receptor function, but it is needed also for a proper transmission of the signal from the nerve terminal to the muscle cell. So there are some other proteins inside the muscle cells that are also somehow related to myasthenic pathology, but we are not sure about their functional contribution yet. But I may just mention this ryanodine receptor, for instance, here on the sarcoplasmic membrane, or on the muscle fibers. There are also some proteins like chitin or cortactin, which are also considered among the antigenic proteins of the myasthenic patient. But the pathology related to them are not yet well defined. So these two molecules that we consider are the main autoantigens of the myasthenia. And myasthenia, in clinical terms, will be considered in different subtypes, as you see. Not only the antigenic features, but also some other features makes the differences between those subtypes. And as you see, the main disease is actually called the early onset myasthenia, meaning that the disease starts earlier than 15 years, mostly in women. The autoantigen in these patients are acetylcholine receptor itself, and the autoantibodies that are produced against the acetylcholine receptors are all IgG antibodies, but IgG1 and IgG3 are the isotypes that are produced in that kind of disease. It has an HLA association, and it is the most common form, as I mentioned. The second most common form is the late onset, similar to the first type, but the disease starts later. Not a woman predominance is seen in this subtype. The antigen is the same, but there are also some other additional autoantigens that are also produce antibodies, let's say. And the antibody subtype is similar to the early onset, and the disease genetic association is somehow weak or is not very well shown, but there are also some, and which is not the same with the early one. The third class is the thymoma-associated MG, which we call TAMG, because it is associated with a thymoma type of tumor in the thymus. So which may be a byproduct, which may be an inefficient, just a coincidental finding, but there are some clues that it is actually inducing the disease or that it is involved in the pathogenesis. And the main feature of this type is actually the autoantibody response is more diverse. There are more antigens that are also targeted in this case, in this type of the disease. And with that, it has many different autoantibodies these patients in the blood. And the disease starts also a bit later at the in later ages. And it is also different in genetic association. There is not a good genetic association shown for these types. And it also has the IgG1 and 3 isotypes, the antibodies against the acetylcholine receptor. And the most interesting subtype maybe of the MuSK disease is actually shown here as the MuSK-MG, because it is totally different from all three subgroups in the antigen specificity as well as in the antibody subtypes, which makes the effector mechanisms related to the antibodies totally different. So as you see here, the MuSK is the same as the autoantigen, and the autoantibody against this is mainly IgG4 isotype from the antibody, which makes the effector functions of the antibodies totally different, as I said. The genetic susceptibility markers are different, so makes another difference between the other subtypes. So, and it is a very tiny group of myasthenics. We have the possibility, we have the chance that we have a higher prevalence of that kind of MuSK-MG patients in Turkey, because MuSK-MG is more prevalent around the Mediterranean, let's say. The northern countries in Europe have less MuSK-MG than we do. So we are, that's why we be more interested in that interesting muscle, in the MG subtype. And lastly, all others that no autoantibodies can be shown easily, let's say, are called seronegative MG, meaning no antibodies could have been shown. But actually, if you look a bit more in detail, you do find some antibodies. But I'm not going into detail of this subtype, because I think it will disappear in the next many years. Just one more thing about the therapy of the treatment of this myasthenics. As you see, all of these myasthenics will be treated with immunosuppression. And in the cases where the thymic pathology is present, thymectomy is the first choice of treatment. So it makes the thymus an available organ for studies as well as for understanding the disease pathogenesis. And in thymectomy is not performed in the late onset because there is mainly no pathology detected when it is taken out. It is more like an age-compatible involution in the thymus. But in the thymoma cases, as well as in the early onset myasthenia, the thymic changes are interesting. In one of them is the thymoma, and the other one is the hyperplasia, which is actually a hyperactivity of the thymus, so to say, because it is like a secondary lympholytic reaction inside the thymus. Just one more thing, the MuSK patients also do not have any thymic changes, which makes the disease again another one, a different one from the other subtypes. So what is the mechanism of the antibodies this effect in the disease? It's shown mainly in the acetylcholine receptor MG. Here you see the antibodies, and if we have the complement system in the plasma, as you see, if the antibody is there, IgG1 or IgG3, it binds the receptor, and with the binding of the complement, a MAC, so-called MAC membrane attack complex forms, and the complement activation system destroys the cell membrane. So the second mechanism is a modulation of the receptor at the cell surface, meaning that binding of the antibody to the receptor induces an internalization of the receptor from the cell surface. So the receptor number on the cell surface decreases, and that is actually causing the dysfunction in the myasthenics. And the last thing, the less important mechanism can be the blocking of the site where actually the acetylcholine was supposed to bind. And this blocking of the site will also induce a negative effect of the signal transduction at the junction. And there is a possibility that the antibodies are not doing any harm to the transmission is also considered among the effects. And in the mask case is very totally different. As I mentioned, mask IRT4 and agrin comes together, and if they come combined in this way, the signal of the mask, the dimerization of mask follows, and the dimerization is actually causing the clustering of receptors. So it is not related to acetylcholine, but mainly agrin, and this combination is the normal function, it belongs to the normal function of the neuromuscular signaling. So mask antibodies are actually, as I mentioned, have other IgG subtypes. So as we have so many mask patients collected over the years by our neurology colleagues, so we have also looked at the isotype of the mask patients at the early stages. As you see, IgG 1, 2, 3, 4, and you see 80 per patient data here. As you see, the IgG4 antibodies are really the majority in all patients. And only a few patients had really more IgG1s than the IgG4. And that was actually, that was a confirmation of the already normal data, but it was interesting to look at these patients, what they might have other than the majority of the patients. So the mask-based antibodies are also very interesting in another feature, which is actually shown here in the slide. As you see here, IgG4 is a specific subtype of antibodies, IgG antibodies. It has different functions, different effector functions, as I said. It also has a function that it actually changes one of the fat arms, so-called, with other antibodies which are present in the plasma. So instead of being bivalent, we call it bivalent, meaning two binding sites for the same antigen. In this case, the antibody becomes monovalent because one of the arms will be derived from another molecule, so that the two sides of the antibodies, two antigen binding sites, will not be same, and this makes the antibody monovalent, so-called. And if the masked antibody is monovalent, it induces different reactions than when it is bivalent, as shown here. And if the antibody binds the mask on the membrane, it can actually be agonistic, have agonistic effect, but if it is monovalent, then in this case it can only be antagonistic and it will not induce any signaling in the membrane. So we understand masked antibody has not only one kind of effect, but it can have different effects depending on the top-up exchange situation. And this is actually happening inside the plasma easily, apparently. So it is an interesting mechanism. So that was, this is actually the neuromuscular junction and the immunology of, to introduce you into the area. And now I'm going to introduce you to our studies that we are actually, how we are approaching the myasthenic pathogenesis in the lab with the patient material. So as we have different kinds of antibodies, you know the antibodies are mainly produced by B cells, and B cells are actually induced by T cells to produce the antibodies. So we are interested in B cells, T cells, and the development of the T cells in the times. So we are not, we are kind of looking back to the understand the production of the antibodies, which are actually different in different subtypes of myasthenia. So in this understanding, we need to look at the B cells and T cells. So B cells are the cells that are producing antibodies, as you know, and the B cells have the B cell receptor that are recognizing the antigen, and then induce then they produce antibody. But for the antibody production, they need actually T cell help. And the T cell helper T cells for the B cell antibody production are mainly called T follicular helper cells. And these kind of cells, this specific T cell subtype, is mainly produced in the germinal centers, in the lymphoid, secondary lymphoid tissue. And this T cell subtype produces mainly IL-21, IL-4, and interferon gamma, and so forth, depending on this, mainly IL-21 and IL-4. And it has different molecules on the surface of T cells that we can differentiate them from other T cells as well. And this T cell group is inducing the B cells to produce different kinds of antibodies like IgG4, IgG1 and 3 and so forth, which is actually interesting for, as I mentioned, in the myasthenia, because we wonder how the IgG4s are induced and how the IgG1 and 3 are induced, and how we can interfere with that induction of the autoantibody. So it may be a starting point. So at the beginning, we have used the PBMC, which is the peripheral blood mononuclear cells of the patient, and we have induced the cells to produce cytokines. And we have looked at the acetylcholine receptor Mg and MuSK-Mg and compared them with the control. And we could detect in the normal cell culture that the IL-21 was produced higher by the T cells in general in MuSK patients, as well as in acetylcholine receptor mediated patients, although it was not significant in this case. And the same is actually also true for IL-12, 17A, and interferon gamma, somehow for the MuSK. And some other cytokines like IL-10, IL-4, and also IL-6 have also some differences, but they were not significantly different in that particular study, where we did not separate the cells and use them as they are directly isolated from the blood. Then later on, we thought as these cells are mainly should be the main follicular helper cells, as I mentioned, we these forms, also in the seronegative ones, although we cannot detect the antibodies. And IL-17 was also increased, and IL-10 also in acetylcholine positive acetylcholine Mg form. And interferon was lower in the diseased patients, as you see here. So the cytokine profile of the CD cells was actually supporting the TFH response. And then we have also compared the immunosuppressive treated and untreated patients in subgroups, whether to see the immunosuppression that is widely used in the clinical daily life is actually also inhibiting the cytokines that may have effect in the antibody production. And as you see here, none of them apparently, almost none of them, is actually affected. The one that I emphasize are not affected by the immunosuppressive treatment. So the immunosuppressive treatment is not enough for treat the autoantibody production. Early and late onset NG forms are also not different. Both of them have the same IL-21 and IL-4 and IL-17 as well, and the other ones were not present. So we then looked at the cell surface markers of the TFH cells, to not only the products of themselves, but also the cell surface markers could be targets of the interaction, for this interaction. And as you see, TFH cells, CXCR5, ICOS, and PD1 are the ones that we have selected from that interaction. And you see there are so many interactions, and these are the ones that we have looked at, because all of them have their ligands on the B cells, and they have to be interacting to induce the B cell to become a plasma cell and then make the antibodies that are producing the disease. But now at this stage, there goes as a new approach, new data, which actually differentiated that TFH cells that can also become have similar functions like the peripheral helper T cells, which is actually which have actually similar surface markers, but they are lacking the CXCR5, but they have CCR2, and they are mainly responsible for the local antibody production, like in the synovium of the rheumatoid arthritis patients, whereas the TFH cells are mainly in the germinal centers of the lymphoid tissue, as I mentioned. So, but they have so many similarities. PD1 is present in both of them, and it's not shown here, but ICOS is the same. ICOS is also present on TFH and also TPA. So, if we wanted to look at the TFH, we also had to consider the TPH cells in the periphery. So, with this as understanding, we looked at the cells, the CD4 T cells of the MAGA patients, CXCR5 positive follicular helpers, or negative T peripheral helper cells are compared. And as you see, again, the acetylcholine and seronegative patients had TPH cells and TFH cells increased in the blood with the ICOS or with the PD1. Both of the molecules were increased in both subgroups of the disease. So we could not differentiate whether the TPH or TPH, but both of them seem to be positive. Then we looked at the TAMG patients, which are the thymoma-associated myasthenia gravis patients, whether they also have the similar features of the T cells that are inducing the B cell response, IL-21 and IL-4 and IL-7, so IL-21 and 4 responses were similar, and there was also an increased IL-10 response here in this patient. And we also take, in this case, the TOMA patient, which is actually patients only with thymoma without myasthenia. So whether the thymoma itself has an effect on the periphery, in the cytokine production, so that it may induce TMOMA-associated NG. And TOMA were mainly different for these cytokines. And the TFH or TPH and TFH cell distribution was also showing us that the TPH actually cells are also decreased in the TOMA patient, but TFH cells did not change, did not differ between the patients. And so TH17 cells were also compared, and again the TAMG patient showed us, and with the ICOS as well. And what we emphasized here in this study, the ICOS molecule, which is actually increased in TOMA, in thymoma, could have actually been one of the molecules in the thymus, inducing the response in this patient. I'll just skip that, and so we are now at the point where we are actually looking at the interactions of the ICOS and PD1 and each CXCR5 molecule, comparing them with each other in terms of antibody production in vitro. But at the other side, there is one more aspect that we were also interested, and the Treg cells, which are actually the regulatory cells of the immune system, controlling the autoreactivity in general, should be actually properly functioning in myasthenia. And this has been shown earlier, and we have shown in here as well, that the Treg cells, so-called CD4 positive, CD25 high, and FOXP3 positive, so we call them, T-rex cells in myasthenia were actually not really, not decreased in the myasthenia, but they have functional incompetence. They were not functionally effective as in the healthy control. And FOXP3 is the functional transcription factor, and it was the main finding about their sun function. And we also could show that the suppression capacity of the T-rex cells in the myasthenic were decreased compared to control. So it could also be a case in this situation that the tiny T-rex cells were not properly developed, and that would have the result that the peripheral T cell activity will be then inducing the B cell response. So the Treg insufficiency or inefficiency is actually a finding that is also already shown in myasthenics, as we have also had shown. And this was also related to the IL-2 responsiveness of the Treg cells. That was also shown already in 2015. In the meantime, there have been reports about the IL-2 as a new intervention for different kinds of autoimmune diseases. As you see here, there are very, very recently, there was a study published and where they put all together 13 different autoimmune diseases all together with many, many single diseases, very small numbers of patients. And in all of them, the low dose of IL-2 has had an effect on the Treg population, and the Treg numbers or Treg proportion of the inside the CD4 T cells were increased with the effect of IL-2. Although IL-2 is a potent inducer of the T cell responses in general, low dose IL-2 is actually a kind of new concept that is checked in it right now. So, interestingly, we had also the chance to look at the effect of the IL-2 in vitro in our culture system. When we cultured the cells of these subtypes again, you see the Treg cells were decreased in both subgroups, and actually acetylcholine receptor MAGE has even lower Treg cells. And IL-2 could induce all of them to increase in general. And here you see the IL-2 treatment, how the Treg cells have increased with the IL-2 in vitro. And not only the Treg cell did increase, but also the increased numbers of TFH cells, PD-1 positive TFH cells, was actually decreased with the effect of IL-2. We have also checked the Treg cells and TFH cells at the same time, because the Treg decrease and the TFH increase were actually together observed in the myasthenics. And the IL-2 could also induce the decrease of TFH cells by increasing Treg cells. So we compared their proportions, whether the IL-2 stimulation could balance the Treg to TFH ratios. And as you see here, these are the ratios, the healthy control, and the IL-2 treated cells in MAST patients and in acetylcholine receptor patients came to a normal level, let's so to say, were comparable to the normal level, and this has been a kind of this has been gave us a kind of hope for the introducing IL-2 in the treatment of MG in the future maybe as well. And these changes related to the IL-2 are also observed in the production of the suspicious cytokines, as I mentioned, IL-21, IL-4, and IL-17. They were all decreased by the effect of the IL-2, and this was actually bringing the increased levels of these inflammatory cytokines to the normal level, to the levels of the health control, so to say. Lastly, I will just give you 2 more slides.
Yeah, 3 minutes.
Thank you. As I mentioned, the timing changes are very interesting. And about the acetylchoreceptor MAGE, about 70% have the hyperplasia and only 10% thymoma. Most do not have thymoma or no hyperplasia, and seronegative MAGE is diverse. And with that in mind, we also try to compare timing changes in the myasthenias. Actually, the main hypothesis about the thymic involvement in myasthenia is that is derived from Sonia's work in generally, and they consider thymus as a tertiary lymphoid tissue where the inflammatory response starts, and then the uncontrolled T cell development causes the hyperplasia, and this is actually the place where the B cells actually are hyperactivated and produce the autoreactive antibodies. And so we had also a chance to have an approach to look at the thymuses at the RNA level. We have compared the thymic hyperplasia sample with the thymoma-associated myasthenia gravis thymuses. They were chosen from the untreated patients, and then we compare the cytokines and the cytokine-related transcription factors that I just have mentioned in those patient groups. And we have come up with a molecule which is called the HIF-1 alpha, which is related to the hypoxia. And we have compared the thymoma-associated MAGE patients with hyperplasia-associated MAGE patients' thymuses. And we have seen the PA-MAGE patients had a higher level of HIF-1 alpha, and the related 2 molecules, also not significant, were also relatively higher in that subgroup. And the IL-17 and Treg-related transcription factors and cytokines were also compared, not fully convincing, but if we made up ratios of these molecules that might have effects on this dysregulated control in the thymus, we do see that the PA-MAGE patients had a higher proportion of the IL-17 related transcription factor and lower Treg-related transcription factor. In both cases, you see that is actually also supported by the mRNA level in the thymus. So in summary, subtypes of MAGE have different mechanisms of autoantibody production. IL-21, IL-4, and 17 seem to affect by both antibody production in both acetylcholine MAGE and PA-MAGE. ICOS and PD-1, both of them are involved, so that follicular helper as well as peripheral helper cells may be targeted for different kinds of interventions if possible. And the decreased Treg and increased B cell helper functions can be potentially regulated by IL-2, which has to be further developed, that we have only put test in vitro model of TMB cells. And now I will show you our nice students, which we have been working with for many years now, and the Istanbul Medical Faculty with the Department of Physiology. All of them are my doctor fellows, and neurologically have helped me so much, and we have all the patients from the neurology and the thymic issues from the thoracic surgeon, and the pathology gave us the thymic pathology results, and Victor has also helped a lot. And I should also mention Kezade Imer, who has actually introduced me to myasthenia and made me a fan of it. And I thank you very much for your attention. and I'm happy to go.
So the presentation is very interesting, especially T cells are very interesting.
Thank you, thank you. I'm also very.
So now we continue with the question and answer sections. Do you have any questions? Yes. Well. So you can ask questions for both talks.
Hocam size böyle bir takdim. Evet.
Thank you for your thank you for your presentation. I want to ask, at the beginning of the presentation, you saw us at tandem and energy was equal in genders or common in women. And it was especially at the premenopausal ages. So, could estrogen have something to do with these results? And if it is, could be maybe selective estrogen receptor modulators in the treatment and thank you.
Thank you for the question. Actually, all autoimmunities are more frequent, more prevalent in women. So there should be some reasons, but we don't know anything about that, unfortunately. I mean, the estrogen receptors have been looked at. I don't know, I don't remember the results, but if it had an effect, I would have remembered. So I don't think that's not that cannot explain the difference, but there must be something because the observation is very clear that the women have more autoimmunity.
Yes. Thank you, Rebecca. Thank you. First of all, thank you both professors for your presentations. It was very inspiring for me indeed. I would like to ask my question to Sir Aksel. My question is that you mentioned that the disease is highly personalized. So if we want to investigate this disease by utilizing artificial intelligence algorithms, how can we keep constant? Like what we should focus on? Should we be focusing on a particular subplanetoid feature or can we target the MS generally? I would like to ask that. And additionally, I would like to ask this, what advice would you like to give the future scientists like me who wish to study MS in neurological and genetic aspects using artificial intelligence methods?
Thank you for your difficult questions. Well, to my understanding, the first question actually related to the second is how to study MS as such a heterogeneous disease with artificial intelligence. I guess it would be artificial intelligence who would give the answer to this question, not myself. The thing is, one thing I probably don't understand very well is that who feeds artificial intelligence? We do. Certainly, I guess by machine learning they go on, but it depends on what information you give. And I don't think that we have any really solid reality related to actually any of the disease. Why do I say so? Because recently we had a discussion with Hans Lassmann from Vienna, who is a leading neuropathologist in the field of MS and related disorders. And he was mentioning about a study made by a histopathology study by artificial intelligence in an MS model. And the outcome was wrong because the information given was not correct. and this is based a little bit on the EAE model and so on the things. So I think we still do have some difficulties in the field of artificial intelligence. I believe AI will help us in conducting our own studies, but if we leave AI to conduct studies with probably not so correct information, we may end up with not very clear-cut or correct answers. So I do have difficulties really to answer your questions because I really don't know how the outcome will be. But simply for a future neuroscientist like you, I would suggest you, like if you want to work in the field of MS, certainly you will consider, let's say, neuroimaging or neurology or whatever. But my first suggestion would be to do some clinical work, or at least work with clinicians together, because you have to understand what happens in the field. I should now here mention Elif Everest, who is now working at NIH doing MS genetics, mainly working with Canadian genetic data. She did a lot of, well, we continue to do a lot of studies with her on genetics, with her mentor, Eda Tahit from Metropolitan University, who was previously also at NIH, now a familiar MS core. And for many years, she's a geneticist, molecular biologist. She kept coming to our MS clinics on Wednesdays and did work with us on other days as well. And that's how productive work came out. So if you're not going to be a clinician, be hand in hand with a clinician. And I think for clinicians, it's the same way. We have to be working very closely together in cooperation with the basic scientists.
Thanks so much, Professor. Is there any...
Can you hear me? Is it on? Yeah. I have actually a question or remark to both of you. So thank you very much. It was really highlights. I learned a lot, I have to admit. I have a question with regard to MS. So you mentioned just briefly the role of the plexus coreus, and you also talked about plexus coreus inflammation. That's the term you use. And so I'm wondering with regard to the plexus, which is a specialized structure, it has not the real blood-brain barrier. There might be another type of barrier, but it's obviously easier for T cells to pass this. And so I'm wondering what actually the role, what's currently known about a lot of the part plexus and is. And the second one I have is a remark with possibly regarded to immunology. So in the past, the brain has been considered as an immunoprivileged organ, and maybe this term is no longer correct. There is a lot of evidence that the lineage, a lot of immunology is actually ongoing. And what I found surprising that, for example, you mentioned T cell interaction, and you mentioned secondary and tertiary lymphoid structures, and there is now actually evidence from a group in Uppsala from Anna Himmler that tertiary lymphoid structures actually assist in brain cancer, which was not known before. She has published on that, and we are in close interaction with her because of similar findings. But obviously, there is quite a lot of immunology ongoing in an organ that has previously considered as immune free.
Yeah, concerning the immune privilege side, the concept has really changed a lot, and the brain barrier do not actually really protect the brain from the immune cells, as we know. It has been shown already earlier, but now the ongoing immune response inside the central nervous system has been definitely shown. As you mentioned, in MS as well, there are also tertiary structures in the meninges, where the B-cell response is going on, as you know. And if you look at the different tissues, now with that concept, with that in mind, everybody finds some accumulation of lymphoid tissue at every tissue, wherever the cells can reach, at the gut, at the different tissues as well. So we should just have another looking at different way. It has changed a lot, really. And the prolate plexus, I think it is actually, if it is healthy, it's still not, if the cells in the periphery are not activated, if they are not directed to the nervous tissue antigens, they are still not able to pass the choroid plexus. But if they are somehow activated in the periphery, then they can cross the barriers. That's the concept in general.
Before I'll try to briefly give an answer as much as I know, I want to advise to young neuroscientists. First of all, like when I'm talking of choroid plexus in MS, that is inflamed, it is bigger. It was always like this, it was not new. So the first thing is to look at things and to see things that are there. I have mentioned again, we didn't look to the astrocyte, we didn't look to microglia many years ago, but they were always active, it's not new. So please try to look and see what is there. And the second one would be try to see what is beyond, what other people did not think. Here I will just briefly quote Stan Prusiner, who is, to my knowledge, the only clinical neurologist receiving a Nobel Prize for his contribution in the crime story. Stan Prusiner and Gatsutek, his mentor, Stan believed in something that sounded impossible at that time, but he persisted in what he had believed, and he had been able to show some evidence. So please look and try to see what others they had not seen before, and think beyond what others had not thought of. Regarding choroid plexus, yes, it is first it was in MS, it was more inflamed, it was bigger. And now they are just starting to correlate with the prognosis. And now the explanation is that why it is bigger, because there's more neuroinflammation, and they have mentioned that. And that probably that choroid plexus is one of the major sources of the lymphatic systems, the glial lymphatic system. It is glial, the lymphatic system of the central nervous system, which now we are just learning. And probably a more active inflammation might be correlated with, I can't say definitely with more neurodegenerative disease, but it will learn. But now when we look to choroid plexus, that is a sign of ongoing more active inflammation in the brain.
Thank you, Professor. Any other question?
Yeah. Thank you to everybody for your questions and contributions.
Güher hocam.
Now, here and organize the groups want to give you some more. We are grateful to Güher-Saruhan for her enlightened presentation.
I'm so impressed of the audience, so I take pictures. At that time of the day, so many still here waiting. We don't see that many students in the lessons anymore, so we miss them. Thank you very much. Thank you.
Professors, thank you for your presentations. And Professor Göze, thank you for moderating and ranking again. All participants, thank you for your participation in our fourth and final session. And you will see a QR code projected on the screen, and it will be available for the next few minutes. Please scan to fill the form for registration. The keyword is glioblastoma. We now have an announcement to make after you're done with the QR code. After careful consideration, we decided to do our closing ceremony before the workshops in order to make the experience as convenient as possible for everyone. Dear guests, distinguished faculty members, and fellow students, as we draw the second International Cerrahpaşa Neuroscience Days to a close, I want to extend my deepest thanks to each of you for your engagement and enthusiasm through our sessions and workshops. We have journeyed through the realms of neurodevelopment and neurodegeneration, delving into molecular, vascular, immune, and psychiatric aspects, enriched by the practical experiences shared in our workshops. Before we part away, I am pleased to announce the results of the giveaway by Hekimnet. We will now connect to Dr. Cem Fuat Atlı, founder of Hekimnet, for the live results.
Hello, everybody. It was a very nice congress. I followed from the today, and now we will make our the first present that is giving is the stethoscope. We will give one stethoscope to one of our members who attend to this congress, and now we are doing the there is the one major candidate, and the second one is if there is any problem with the first one, we will have the second one. We can take a screenshot of this. Okay, and now we have Harrison pocketbooks 5. And this is the list. I hope you will benefit with these books. They are very good books actually that every student must have in his or her packet. Okay, so we finished the takeaway.
The results through the WhatsApp group as well. Once again, we extend our sincere thanks to Hekimnet for being our broadcast sponsor and being by our side through the entire event. I hope insights and discussions from these days inspire your ongoing work and foster new scientific collaborations. May the relationship formed here lead to future breakthrough in neuroscience. Thank you once again for your valuable contributions. Wishing you all enjoyable workshops and looking forward to our paths, crossing again to next conferences. Thank you again, and we will guide you through the workshops. You can find my team members also here to guide you. So thank you again for your participation and for your attention. And please do not stand up. We will take a photo together.
Nasıl yapalım?
Ortaya doğru gelin.
Can everyone gather in the middle?
Söylemeden kapat. Şeye baksana.
Last one. Yes. Thank you for your
Rica ederim.
Thank you.